Three, two, one. We are live now, sir.
Hello, good afternoon, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Foxy Symbiosis Series, Webinar 12, on the topic Practical Obstetrics Problems Tackling Head On. Before starting the webinar, we would like to have a small line planting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Now, I would like to introduce Dr. Monica Singh. Dr. Monica Singh is consultant reproductive medicine, Bhopal Fertility and Endoscopy Center. She is professor at LL Medical College, Bhopal. She is managing committee member, ISAR. She is West Zone Coordinator, Medical Disorders Committee, Foxy. She is also the convener of ISAR Perfection Series and this Foxy Symbiosis Series. I would like to hand over the session to Dr. Monica Singh. Over to you, madam.
Thank you, Dr. Vishal. And thank you, dear respected faculties, for joining us today on the 16th of May, beautiful afternoon of May, summer afternoon, which we will spend in our cool, chambers or homes or hospitals, listening to these wonderful stalwart speakers we have today. And today, as mentioned by Dr. Vishal Dave, and Intas is our pharmaceutical academic partner. Since the last 1.5 years, they have been doing wonderful programs with Symbiosis and with Perfection. So this we are thankfully, thanks to God, thanks to all faculties, we are on the webinar 12. And this time we have made a very important, combination of practical obstetric committee with medical education committee, because there is no other committee than medical education, which can determine guidelines for practical obstetric problems and how we should, inculcate these guidelines into our practice in order to have a safe obstetric and gynec practice. I also am thankful to Bhopal Obstetrics and Gynec Society, my parent society, and Nagpur Obstetric and Gynec Society, headed by Dr. Sandeep Nikhade and Dr. Rujita Phuke, and my dear friend, Dr. Pragati Khalatkar, all of them from Nagpur Society who have joined today for this event. The title of today's webinar is Practical Obstetric Problems and How Do We Tackle Them Head On. We should know how to, basically go about it without faltering, without fumbling, and with the good surgical knowledge and skills. This webinar has been awarded 3 ICOG points by the Indian College of Obstetrician and Gynecologists, the academic wing of Foxy. I thank of Foxy office bearers, President Dr. Jaideep Tang sir, Secretary General Dr. Madhuri Patel madam, our VP West Zone Dr. Ajay Mane sir, our Chairperson Practical Obstetric Committee Dr. Mitra Saxena ma'am, and our Chairperson Medical Education Committee Dr. Kiran Pandey ma'am. From Bhopal Obs Gynae Society, I would like to thank my President Dr. Anita Srivastav ma'am and my Secretary Dr. Shabana Sultan. Nagpur Society, I've already thanked profusely from the bottom of my heart. I would also like to thank my co-convener, Dr. Randhir Singh, and my dear program coordinators, 3 very, very active girls, Dr. Manisha Jain, Dr. Neetu Mishra, and Dr. Purva Patko. So without wasting time, I would like to straight away start the introductions. I thank Dr. Jaideep Tank, and Dr. Jaideep Tank and Dr. Madhuri Patel ma'am are right now, I think, in Korea for a program of international gynec meet in Korea. So I think, Dr. Vishal, we can straight away go to Dr. Ajay Mane's slide. I thank Madhuri Patel ma'am for this opportunity and always blessing us. Dr. Ajay Mane is Vice President Foxy, West Zone. And Dr. Neetu, can you call him? If sir, I called him. Yeah, so I will introduce Dr. Ajay Mane when he joins. He has been very benevolent in his, efforts to always promote and encourage us in our programs. And we are also fortunate to be doing the West Zone Vice President Conference, the National Conference of Vice President West Zone in Bhopal on 12, 13, 14 July, for which I extend a very warm welcome to all faculties, all dear friends and dear colleagues from all over India to have the one in a kind experience in Bhopal this year. I would next like to now happily introduce and welcome our committee chair, Dr. Mitra Saxena. And again, Mitra ma'am, I would like to introduce when she joins. She is the current chairperson of Practical Obstetrics Committee. I talked to her just in the morning. She has a little bit of sore throat problem, so she might be just resting for some time, and then she's likely to join after 5. Kiran ma'am is there always in my programs, and madam is like a constant, uh, guru or a mentor who is always there to bless me. She has met me so many times in physical meetings as well as in virtual meetings. And always I find a very deep connect with Kiran ma'am. And she's always, her every query, every request is always draws a yes from her. So I can vouch for her students. They must be so fond of Kiran Pandey ma'am. And I'm delighted to introduce her as our honored chairperson of Medical Education Committee, FOXY. Professor and former HOD, Department of OBGY, GSMVM Medical College, Kanpur, Professor GMC Jalao UP, and ICOG Governing Council member 21 to 23. Madam is the peer reviewer of the Indian Journal of Obs and Gynae since 2021, President Kanpur Menopause Society, President UP State Chapter AGOI 24 to 26, and past President Kanpur Obs Gynae Society and IMA. With more than nearly 40 years of teaching experience, in various capacities in medical college with active participation in all FOXY activities since the last almost
Thank you. Thank
more
you.
than 35 years, organizing chairperson and head of so many workshops, seminars, and conferences, and recipient of awards. And we keep reading her books. She is the Foxy Achiever Award recipient and Foxy Appreciation Award recipient, and awarded Usha Saraiya Oration first time in North India in 2021. We are honored to have you amongst us, Kiran ma'am. And
What
we,
I see is
we would like
there
to
are
have a
many
few words
issues,
from you.
as many people have pointed out. I see.
Monica,
Should start the module
would
based
you
on
like
existing
me to
law.
talk now because our chief guest is also there. Dr.
Accommodate
Shyam
and
Desai has joined.
Yes,
this
ma'am.
is not going to
Ma'am, you can just speak a few words and then we will go
Okay,
to the dignitaries
okay.
introduction. Yeah, ma'am.
Thank you very much. At the outset, really, I'm very thankful I have got this opportunity to talk in this Symbiosis series, which is being organized by uh, which is with being organized by various committees coming at one platform, and the Monica being very active and at the core of these programs, who is organizing it. So, Monica, you are the first thing is all the best to you. We are all very hopeful and very wishful that you will be there amongst us very soon. And you are doing great efforts, and these programs, which are of practical use to all obstetricians and a young budding gynecologist also, they have selection of the topic is definitely from their point of view that they learn more and more things. I'm really little disturbed that Mitra is not feeling well, but definitely she will come. And internal artery ligation, her topic is also very important. Like, I am always favor of this. I used to teach this to my students always present, I mean, 1 year back till, and I'm still doing it. So I'm very happy about it. I welcome our chief guest, Dr. Shyam Desai, one of the very, I mean, I would say I am very, I always feel very respectful for him. He is, though he must not remember, but I have done my laparoscopic training long back in 1995 from under his laparoscopy training. That was the ones he started. So I have that lots of regards for him, and he's a very highly educated and very cooperative person, always very down to earth. Sir is a president of SEPOG also at the moment. And I'm thankful to Bhopal presidents, Bhopal Society President, Secretary, and Nagpur Society President, our guests of honor who are there, our own Dr. Kanchan is there, Dr. Vinita is here. Am I missing someone? All the dignitaries, you have brought so many at one platform. That's really very, very great. All the chairpersons, you are all welcome. And I think let's start with the academic session after the blessings of our chief guest and hearing his words. Thank you, Vin Monica, once again for making me part of it.
Thank you. Thank you so much, Kiran ma'am, for your blessings. And with great delight and a lot of happiness, we introduce our chief guest for the evening, Dr. Shyam V. Desai, sir. And sir, we will always remain indebted to you for, being here in this program at such a short notice. It was early morning one day. I placed a call. I'm a person who rings up in the morning. So there are some people who are taken aback. But still, I feel that that is the time when you are, I think, more, receiving of all the messages, and you tend to remember the person as well as the message. So, sir, I talked one fine morning to sir, and he said yes at the first instance, though doesn't know me very well. But we have interacted physically in Banaras, then in Kolkata recently. So, Sham sir, thank you for including us in the CEFOG groups, which has got great academic activities. As we can see from his illustrious CV, Sir is President CEFOG 23 to 25. He is the Chairman Board of Trustees of Mumbai OBGY Society for 7 years till May 23 and Chairman of Maternal and Perinatal Health Committees of AOFOC 2009 to 2013, Vice Chairman of ICOG in 2006, Past President of FOXI 2005, Past President IAG 2003 to 2005, Past President MOGS 2000, and teacher at Mumbai University for 30 years. Sir is a highly decorated obstetrician, gynecologist, endoscopic surgeon at Hinduja and Nanavati Group of Hospitals, Mumbai, an honorary professor at Wadia Hospital since last 25 years, and also consults at Port Trust Hospital. So we are blessed to have you amongst us, and we can't wait to hear from you, sir.
Thank you for those very kind words. I'm indeed honored to be part of this webinar. I'm honored to be included in your group, which is discussing such important obstetric problems. And obstetrics, as you know, is our bread and butter. And if we are able to improve our handling of obstetric patients by improving our skills, there's nothing like it. We all know that postpartum hemorrhage is an acute problem which suddenly comes up without much notice. And if we are able to tackle it right till the end, where we can ideally stop the bleeding and yet conserve the uterus, we are in a very, very good position. Of course, obstetric hysterectomies can always be done, but if you are able to do the internal iliac artery ligation and you learn it at a very early stage when you're residency, you are able to confidently say that, well, we are able to tackle even the most severe of postpartum hemorrhages. Now, not only is postpartum hemorrhage control with internal iliac artery ligation, but even gynec situations where you sometimes have a patient who's undergone a hysterectomy or a vaginal surgery, and the patient starts bleeding, and the bleeding is not from one particular oozer or one particular bleeder, but it's a generalized ooze. If you are able to do an internal iliac artery ligation, you are very, very competent in stopping the bleeding. Of course, there's also a very important topic that you're going to be discussing. It is SLE in pregnancy. That also is a very important topic. And even though we do not see too many patients, when we see a patient, we should be able to handle the problem. I congratulate the organizers for having set up this particular program. And I thank all the dignitaries on the panel for having included me as a chief guest. All the very best for the program.
Thank you. Thank you so much, sir, for your kind words. And we are indeed blessed to have a figure like Dr. Shyam Desai amongst us and speaking so lovingly to us, encouraging us. And now, with great pleasure, I invite our guest of honor for the evening, Dr. Vinita Singh ma'am. She's with us right now. And can I have a CV, Dr. Vishal? Madam, as we can see, is the East Zone coordinator of MTP committee of FOXY, and she is at present the Associate Professor, Department of OBGY at NMCH Patna, Consultant Care Hospital and IVF Center, at present holding the post of East Zone Coordinator of FOXY and Governing Council member of ICOG FOXY 23 to 24. Madam has been the past president of Patna OBGY Society, which is a very vibrant and a very important society out of all the FOXY societies. FOXY ICOG Governing Council member, YTP Committee Chairperson FOXY 2017 to 19, and held various important executive posts in POGS. She has been the member of so many committees of FOXY, been very active in the organization, and also the business secretary of the Patna Journal of Medicine and the East Zone coordinator of MTP Committee FOXY. She has been the organizer of several important conferences and workshops like Nikon 19, and she's been invited faculty in international conferences like FIGO Rio and FIGO Vancouver, organizing secretary of BoxCon. She has edited FOXY ICOG campus on PCOD and has been awarded the MG Mishra Award in 2004, George Mohanty Award in 2012, and the Economic Time Award. We are so honored to have you amongst us, Vinita ma'am, and we would like to have a few words from you.
Thank you, Dr. Monica, for such a nice words. I'm really delighted and very good evening to one and all the participants. And I would like to thank Dr. Monica Singh, Vice President, Bhopal Opsangani Society, for giving me opportunity and honoring me by making me part of this prestigious program, Foxy Symbiosis Series webinar, which always pick up very practical topics, which is beneficial to all practicing gynecologists, especially the budding gynecologists. And I'm really delighted to see legendary personality, Dr. Shyam V. Desai sir, as chief guest, Pranam sir. And I will never forget you, sir, since 2002, you have given me, blessed me, and you had given me a book of laparoscopy. So I will never forget, that incident. Until then, you have, you are blessing me. And I'm really delighted to see my friends, Dr. Mitra Saxena, and my dear friend, Dr. Kiran Pandey and Kanchan Sharma, who is part of this program. I'm really thankful to Dr. Anita, President and Secretary, Dr. Shabana, Bhopal Opsangani Society, and also Dr. Sandeep, President, and Dr. Rujita Phuk, Secretary of Nagpur Society, for making me part of this program. I can never forget Dr. Rujita. You had worked with me when I was YTP committee chair. So you had worked a lot with me in that tenure. I would like to congratulate organizers for such a well-crafted program of today. We have taken all the important topics. So each and every topic as inter-iliac artery ligation, SLA in pregnancy, and especially case-based management of PPH. I think PPH is, since incidence of PPH is rising, previously it was 35%, now it's 38%. So everyone, even FIGO with FOXY, all are worried about managing PPS and reducing MMR. So I'm really thankful to organizers and my all blessings to have a very successful program, and my best wishes to my friend, to Dr. Monica, for her success in her future endeavor, because we need, Monica, a very active Foxian like you among us. So thank you very much, and all my best wishes for today's program.
Thank you. Thank you, Vinita ma'am. Thank you for the nice, kind words and blessings. And I would also like to now introduce our another guest of honor, Dr. Kanchan Sharma ma'am. She is there with us right since the beginning. And one thing I must say is before the webinar starts, 10 minutes before the webinar starts, any webinar, I've always seen Kanchan Sharma ma'am log in at the very first. She is so, and that speaks volumes of your punctuality and your dedication to time and your time management. And here we are running after minutes, but madam has got, even hours in her control. So I would like to introduce Dr. Beautiful Kanchan Sharma ma'am. She is the chairperson of NCD committee with a very well contested elections last year. And she also, organized a very beautiful mega conference of NatCon in Kanpur, which we were a part of. Madam is the recipient of Foxy Achiever Award. Madam has held various posts in Kanpur Opskyni Society, again a very, very important society of Uttar Pradesh and northern part of India. Her chief interests are in ART and endoscopy. She is also a renowned colposcopist, has been trained all over India and abroad. And she has been awarded not only the Foxy Achiever Award, but also the Pratigya Social Impact Award, Empowered Woman Award, Nari Ratna Samman, Corona Warrior Award, Nari Suraksha and Nari Samman Award from Police Commissionerate Kanpur, and the Lifetime Achievement Award from Cox Kanpur. We welcome you, ma'am, Kanchan Sharma, ma'am, and we would like to have a few words from you, please.
Thank you for lovely words, Dr. Monica. First of all, I pay my sincere thanks for having me here as a guest of honor in such a prestigious Foxy Symbiosis Series webinar episode 12. My good wishes to all the 4 committees of Foxy Practical Obstetric Committee, Medical Education Committee, Bhopal Obstetrics Committee, Medical Education Committee, and Nagpur Obstetric Gynae Society. All have joined hands together for talk on so many important topics. My sincere respects and regards to our chief guest, Dr. Shyam V. Desai, sir, who is president of CEPHO 2 and enriched with vast ocean of knowledge. Sir, under your guidance, we will work a lot and gain further experience. My sincere love, best wishes, and congratulations to our today's sweet convener, Dr. Monica Singh, Vice President of Bhopal Society, who is contesting for Chairperson of Foxy Perinatology Committee. Dr. Monica, you simply deserve for it. And congratulations to your sincerely devoted husband, Dr. Randhir Singh. I have seen your performance and sincerity in Kanpur conference. 3 program coordinators, Dr. Manisha Jain, Dr. Neetu Mishra, and Purva are always very devoted and wonderful. My co-guest of honor, Dr. Vinita Singh, and special guest of honor, Dr. Pragati Vasant Khaledkar. I always appreciate both of you. Always, you are full of knowledge and fun. The topics chosen are great, will definitely enhance the skill and knowledge. Again, my best wishes and full support to Dr. Monica Singh, and thanks for having me here. Thank you.
Thank you for the beautiful words, Kanchan ma'am. And I would now like to complete our dignitaries, honor of dignitaries, by speaking. Mitra ma'am has also joined. I'll just introduce Dr. Pragati and go on to our chairperson, Mitra ma'am. Pragati is a special guest and she holds a special place in my heart because we have done MBBS together from Bhopal. And then she got married and she shifted to Nagpur. And we congratulate Pragati because she is going to be the first lady of pediatrics in India next year in January, because Vasant sir is taking over as IAP president. Again, after a lot of grueling hard work and lot of, he's one of actually the very inspiring figures for me. So as we can see from her biodata that Pragati is active not only in Nagpur, but all over Foxy in India. She is very well known for the pelvic anatomy project, which she and 3 of her colleagues from Nagpur, they collaborated together with Pelvic Anatomy Revisited. And this was a very interesting module in which they taught pelvic anatomy in a very fun, colorful way. And they got the honor to present this, and they were awarded for this in Figo. I think it was in Figo, Brazil, Pragati. So she is very active, and she's also written the lyrics for Pedicon song, AICOG song, EMOC song. She's always active in all the cultural activities. Notwithstanding, she's also a brilliant academician. She's got 2 brilliant children, and we can't believe that you're already mother-in-law. So Pragati, thanks for being here. And I won't read your whole CV. We'd just like to have a few words from you. You're muted, Pragati.
So, a very good evening to all. Respected Chief Guest, Dr. Shyam Desai sir, Guest of Honor, Dr. Vinita Singh ma'am, and Dr. Kanchan Sharma ma'am. It is really an honor for me that today I am here for a Symbiosis Series, and that too post Mother's Day. So, Foxy is our mother. Foxy is our mother, and it has so many societies with it. And Monica is my dear friend. I call her meticulous. Monica, she's a meticulous person and doing all the things so well. So Foxy societies come together to work for a mother. That is this PPH, this practical obstetric problems and tackling head on. Beautiful topic selected for today's 12th Symbiosis series. I'm really full of honor and full of happiness that Nagpur and Bhopal OBGYN societies are together doing this program. So my heartfelt thanks to uh, Dr. Anita Srivastava, President of Bhopal OBGYN Society, Dr. Shabana Sultan. They are very good friend of mine. Dr. Anita is my schoolmate. Even before Monica came in my life, Dr. Anita was there. Dr. Sandeep Nikhare and Dr. Rujita Fuke, they are working so well for Nagpur OBGYN Society, and they are thorough academician and thorough, fun-loving person and fitness freak. I'm thankful to all the members who have joined today. I'm so happy to see again a very good example of symbiosis. That is Dr. Monica and Dr. Randhir. Since ages, I am seeing this symbiotic relationship which is going on so well for themselves and for the well-being of motherhood. And especially they are working tirelessly for the people who are really dreaming to have child, and they have done so wonderful work throughout the country. Program coordinators, Dr. Manisha Jain, Dr. Neetu Singh, and Dr. Purva Badkul. I feel I should mention the names of all my colleagues from all over the India. Dr. Bharatpur from Akluj, Aurangabad, Dr. Trivandrum, Dr. Prasad from Kolhapur, Dr. Archana from Baroda. We have all come in under this roof of Symbiosis. Dr. Anjali from Nasik, Dr. Bhagyashree from Aurangabad, Dr. Deepali from Akola, Dr. Megha from Savangi, Dr. Sangeeta Wagh from Nasik, Dr. Shalaka from Akola, Dr. Pranita from Pusad, and Dr. Supriya from Gadanjiyat. So really, I'm very much happy to be with you all, and I feel honored to be here. So let us, without ado, we should move ahead for the program, and I really am very sure that Monica will be seen at the level where she wants to reach, and we have a wonderful VP Con waiting at Bhopal, where being a member of Bhopal also, I request all to come and join the program and see the skills which Monica and Dr. Randeep put in to organize a conference. Thank you all.
Thank you.
Dr.
Thank
Mitra
you.
ma'am, Dr. Mitra ma'am, I can just see you. I hope you are well. Dr. Kiran Pandey ma'am, thank you. The committee chairperson. Thank you.
Thank you. Thank you so much. Thank you so much.
Thank you, Mitra ma'am. How are you? Namaskar, ma'am.
Mitra ma'am is amongst us, and Mitra ma'am, you are
आवाज
looking.
निकलेगी तो ठीक है
मैडम आप इतने अच्छे लग रहे हैं, मुझे तो लग रहा है आपकी आवाज भी ठीक हो जाएगी मैम.
मित्रा जी नमस्कार. हम लोग को देखकर आपकी आवाज ठीक हो जाएगी.
आराम आराम से वो करिएगा.
Ma'am, you can keep a cup of, take sips of hot water in between, madam. Ma'am, just take a cup of green tea or hot water in between. And Mitra ma'am, I'm really thankful. In the morning, she was in such a, bad throat, but still she has joined. And that's the spirit, to dress up, show up, and never give up. So I would like to introduce Dr. Mitra Saxena, Chairperson, Practical Obstetric Committee of FOXY 21 to 24. Madam has recently written some very nice reviews on Facebook. And that made me realize what a lovely writer she is. I always I thought of myself as a good writer and speaker, but when I see people better than myself, I feel that there is something to learn. So Mitra ma'am, I have seen your reviews, and that speaks volume of the amount of knowledge you must be having in every subject you read. So we can see her publications, editor of Foxy Focus Life-Saving Obstetric Surgeries, which is very much the theme in Sync today. E-Bulletin Building Bridges in Corona Times, so she has worked actively that time also. Convener of Foxy GCPR on Birth After Cesarean section, member of Foxy GCPR Ectopic, and so many chapters on, volumes on active obstetrics, emergency obstetrics, we can see it. She's also been the organizers of wonderful state level and national conferences and workshops. And her topic for today she's done physical workshops on internal iliac artery ligation. So we are really, very fortunate that all of us can, listen to her and take those skills from her and try to inculcate them in our working. So ma'am, we are really, amazed to see your CV. You are the member of so many societies and been recipient of Foxy Dhira Award, Foxy President's Appreciation Award, IMA Achiever Award, with areas of interest as varied as high-risk obstetrics to contraception, colposcopy, and of course, the director of Shri Ashwini Saxena Hospital in Rewari. Again, ma'am, congratulations. Madam did a very big function of, it was a Founders Day of our hospital, which we enjoyed through, again, her pictures. And Madam, we are blessed to have you. And thank you for the opportunity you have given to Symbiosis. We would like to have a few words from you, ma'am.
Thank you. Thank you so much. Actually, really, I apologize for my horrible throat. And I actually want to save my throat so that I will be able to give the talk. Please, Monica.
Yeah,
Actually, मुझे एक ही बात लगती है कि फॉक्सी में एक से एक बढ़कर सितारे हैं. And the good thing about Foxy is when we find that there are similar type of people, it actually energizes us. हम सब अपनी अपनी जगह काम कर रहे हैं, पर हमें पता चलता है कि हमारे जैसे बहुत सारे मित्र हैं. For me, Foxy is a place where I have found fantastic friends. And definitely from my side, Monica, I wish you the best of life, health and success. जो भी काम करते हो तुम वो मन लगा के करते हो तो ईश्वर उसमें कामयाबी जरूर देगा. And I can see so many stalwarts here. Before me, Dr. Shyam Desai must have spoken. I joined a little bit late. I'm so sorry. Dr. Vinita, Dr. Pragati, Dr. Kanchan. So everybody, and of course, Dr. Kiran Pandey, I can see Madam here smiling away. And to all, and you are very fortunate, Monica, that your life partner, Dr. Randhir, is in the same specialty. And then he is your, जिसे कहते हैं ना, perfect symbiotic partner. ठीक है ना? So we thrive on each other and with our friendships. So best wishes for a good learning today. Thank you for giving me a topic which is very close to my heart.
Thank you so much,
So
ma'am.
shall
Ma'am, you
carry
would
on
like-
with the,
Yes, ma'am. Ma'am, you would like to have the third talk, no? After the two talks.
as you wish, I can take it now also. गला तो वही है.
ठीक है,
मैडम
ma'am.
से डॉक्टर किरण से पूछ लीजिए जैसा
Uh,
उनको चाहिए.
You can do anything, or we can do actually. My two talks are also continuous, so I can do this also. Ki I take one, then you take, then third one. So
आपको आप लोगों
there
को
will be a
कैसा
little
ठीक
bit
लगे?
of gap in between also. People will become
As
bored by seeing one face for a longer
नहीं
time.
आपको जैसा ठीक लगे. I've logged.
So I will take one Sally, as she said, and then you take it, and the third one I will again take it, so that the second
that seems good. Yeah.
that will be okay.
Thank you. Thank
Is
you
it
so
okay,
Doctor.
Monica?
Yes, ma'am.
Is it
Perfect,
every?
ma'am. Perfect, ma'am.
Okay.
Perfect. So now I would just give a short, a word of thanks to our my home society and my guest society. Thanks to Bhopal Obstetrics and Gynec Society for collaborating with Symbiosis in order to present this webinar in front of you. Our illustrious president, Dr. Anita Srivastav, and our secretary, Bhopal OBGY Society, Dr. Shabana Sultan. Dr. Anita is there, Manisha?
Not is it?
Okay, Dr. Shabana, I can see.
Yeah,
Dr. Shabana, are you there?
Yes, I'm here.
Yeah, please. We would like to have a few words from our secretary. He's also the HOD of the biggest government medical college in Bhopal, that is GMC Bhopal, our alma mater. And Dr. Shabana, we would like to have a few words from you.
Yeah. I'm privileged to be a part of this Symbiosis 12. And on behalf of Bhopal Obigana Society, I welcome Nagpur Society and all the dignitaries, respected Shyam Desai sir, Dr. Kiran Pandey madam, Dr. Vinita Singh madam, Dr. Kanchan Sharma madam, and my dear friend Pragati. And of course, the president and secretary of Nagpur Obigana Society, and a good combination of a Foxy practical committees plus Foxy medical education committee, that always a good combination done by Monica madam. And I have so many best wishes to Monica ma'am for her election. And thank you so much for making me up to this. And the combination of the topic really is, they're very important for the maternal health. And topics are very near to my heart also, that is postpartum hemorrhage. So thank you so much.
Shabana has been very active in the PPH bundle in Sevagram. She is doing so many projects with international organizations. So Shabana, I think you will be a very good expert to stay on in our webinar and give your expert comments. We would like to have you
Thank
from
you so
you.
much.
And next, I would like to welcome and thank our dear Dr. Sandeep Nikhare, who is the President, Nagpur OBGY Society and Director of Lifespring Hospital and Parvati IVF Center at Nagpur, and a very skilled laparoscopic and pelvic surgeon. His fame reached me well before he became president from various quarters. And now Sandeep and I, thanks to Dr. Pragati, we are, very great friends, and we are also quarreling at times. So, Sandeep, we are, really happy to have you, collaborate with us for Symbiosis and also do the panel for us. So as we can see, he is the recipient of Foxy's Dr. C.S. Dawn Award at AICOG Kolkata, which was a very, very super hit conference, and winner of IAG Annual Conference Endoscopy Video Award in 21, winner of Dr. M. Rotaki Award for Endoscopy in 2020. He has organized IAG Gynecology Laparoscopy Live workshops in 16 and 22, performed more than 15,000 laparoscopic procedures. So, Dr. Sandeep, we would like to have a few words from you.
Yeah, madam. It's a very honored, I'm very honored and obliged to you for giving Nagpur Obstetric Society to become a part of such type of webinar where we are dealing with life of mother, and this such type of webinars will definitely help the all the audiences who are listening to this webinar. I wish you all the best for your future endeavor and the future election also. And thanks for giving us this opportunity to become a part of this webinar. Thank you, madam.
Thank you, Dr. Sandeep. Thank you for being short and sweet. And we have another sweet girl with us, Dr. Rujuta, who happens to be the sister of my friend Rashmi. And yeah, at this stage of the webinar, before we start academics, I would like to, wish my dear friend Archana, who is very much there in the program, Archana Dwivedi, who is also contesting for Foxy Committee election, and Dr. Rujita's sister, Dr. Rashmi Kahar, who is also contesting, the very best.
Thank you, ma'am. Thank you so much.
So Dr. Rujita has, thank you, Archana. And Rujita has recently taken over as secretary after Dr. Pragati of the, Vibrant Society of Nagpur OBGY Society, which Pragati told me has nearly 580 members now. We can see if he is, yes. She's Associate Professor, Department of OBGY at GMC Nagpur, an examiner of various levels of exam in Maharashtra University, runs a very active cervical cancer screening and colposcopy clinic at the, GMC Nagpur. And we can see her interest in colposcopy, fetal medicine, maternal and child health, been the recipient of so many awards, and with special area of interest in high-risk pregnancy, medicine, and preventive gynec oncology. Rujita, we would like to have a few words from you.
Yeah. Thank you, ma'am. Thank you for that kind introduction. Very good afternoon to all of you. And I'm really privileged and very delighted to be here on this national platform to be invited from you. And I really wish all the best for this 12th Symbiosis webinar. And very congratulations to you for successfully running all these webinars. And we can see the sounding success of all these webinars. And at the same time, I would like to wish you all the best for all your future endeavors and elections. Thank you so much, ma'am. Thank you.
Thank you, Rujita. And that brings us to the end of the introductions. And now I hand over the session to my three brilliant coordinators. Any program has to run on the coordinators, and this would not have been possible without my co-convener, Dr. Randhir Singh, who is also my soulmate and my symbiotic partner. And next, I would like to thank Dr. Manisha, who is, professor at People's Medical College, Bhopal, Neetu Mishra, who is associate professor at AIMS Bhopal, and Purva Bhatkur, who is assistant professor at GMC Bhopal. And we have now a new addition in our team, Dr. Nandini. Dr. Nandini has joined us recently, and Nandini is saying we will include her picture next time. So because of these four coordinators, I just have to give their names and they take the program forward. So over to all of you. Dr. Manisha, you can start.
Thank you so much, ma'am. It's my extreme honor to be part of this esteemed series today, and thank you for making me part of it. With the blessings of God and all the senior respected dignitaries present here, Dr. Shyam Desai sir, Mitra Saxena madam, Kantan Sharma madam, and all, and the President and Secretary Nagpur Ophthalmic Society. I welcome you all. And to begin with the academic session, the first session will be by Dr. Kiran Pandey ma'am. And to chair her session, we have with us Dr. Bharat Pawar and Dr. Lalita Bajaj madam with us. Dr. Bharat Pawar sir is the director of the Anand Hospital and director of Vatsal Fertility Center, Akluj, and is the president of Akluj Ophthalmic Society with special interest in preventive obstetric and sonography and infertility. Next, we have with us chairperson, Dr. Lalita Bajaj madam. She is the president of AOGS. She has also served AOGS in capacity of secretary, vice president, and cultural secretary, and has immense work experience in different settings, Mission Hospital, and then Shirodkar Maternity, MGM Hospital, Vardia Hospital, Kama Hospital, and many more. I welcome you, ma'am. Her special area of interest is high-risk obstetrics, and I'd like to request our chairpersons to kindly introduce our esteemed speaker for today. And over to chairpersons. Thank you. Over to chairpersons now.
Good afternoon.
Hello. Good evening. Bharat sir, you can speak.
Yeah. Thank you, ma'am. Good afternoon. I thank the organizers for giving a chance to chair this session and to introduce our today's first speaker, Dr. Kiran Pandey, madam, who is Chairperson Medical Education Committee, FOXY. She is professor and former HOD, Department of Obstetric and Gynec, GSVM Medical College, Kanpur. Madam is presently professor of GMC Jalun, UP, ICOG Governing Council member 2021-23, peer reviewer of Indian Journal of Obstetric and Gynec since 2021, president of Kanpur Menopause Society, president UP State Chapter AGOI 2024-26, and past president KOGS and I. Madam has a more than 36 years of teaching experience as associate professor, assistant professor, and professor. She is active participation in all activities of FOXY from 1988. Madam has organized many workshops and seminars as an organizing chairperson and secretary. She has many research activities to her name. She was the editor of textbook of evidence-based practice for management of high-risk pregnancy, conveyor of JCPR on management of nausea and vomiting in pregnancy and hyperemesis gravidum, and original research in the field of cancer with IIT Kanpur for 12 years. She has many awards to her honor, 75 national and state, 10 state level and 10 district levels, and more than 40 awards by IMA and Rotary Club, FOXY Achiever Award and FOXY Appreciation Award, and many more awards. I hand over directly towards Madam. We are eager to hear from you, ma'am. Kiran Pandey, ma'am.
Thank you, Dr. Bharat. Thank you very much. Please allow me to share my screen and I hope I am visible.
Yeah, ma'am.
Is my screen visible?
Yes, ma'am.
Okay. So thank you, Dr. Monica, again for giving this wonderful opportunity. Well, as Dr. Shyam Desai was saying, I have selected this one topic, SLE in pregnancy, which you agreed that it is a rare complication. Rarely one sees these patients, but once they see it, then it becomes really problematic how to deal with them. So there one should have knowledge how to diagnose and how to manage. That becomes a crisis, it may become. So let me see my slide is moving. I hope you can see my slides, please. Hello?
Yes, ma'am.
My slides are moving. Is it okay?
Yeah,
Right.
It's visible.
Right. So let's first define what it is, because as I told you, it is an uncommon problem. So one has to be very clear about it. Well, as a definition, it is a chronic autoimmune disease in which organs and cells undergo damage initially, mediated by tissue binding autoantibodies and immune complexes. Its a nature is remitting and relapsing course. Now, these days after Corona, I've seen autoimmune and diseases are becoming little more common. So maybe sometimes one can come across. 90% of these patients are of a childbearing age. Again, that is important for women. That if you see the women versus men ratio, it is 9:1. During the childbearing age, this further almost nearly doubles, 15:1. Highest prevalence, luckily, is not in India, but Afro-American and Afro-Caribbean women. And the incidence overall is 1 in 1,000 women. Now, how does it happen? What is the pathogenesis? Basically, there are interactions between the susceptibility genes. The women has to have those susceptibility genes, and their interaction with environmental factors results in abnormal immune responses, and which vary between different patients. These environmental triggers can be very, very simple, one ultraviolet light or even the viral infection. And that's what I said, after Corona, we are seeing the increase in the autoimmune problems. Now, basically immunologically polyclonal B cell activation occurs, impaired T cell regulation of immune responses, failure to remove the immune complexes which are forming by their antibodies, and circulating non-organ specific autoantibodies, meaning by it can go to any organ of the body, not that one organ only. So that is further problematic. Now, so how does it present if one happens? Now, various system-wise, I will tell you. Generalized, a person might come as a fatigue, malaise, fever, anorexia, weight loss. In muscles, arthralgia, non-erosive polyarthritis, hand deformities can also occur if not properly understood, myopathy. Many a times you might find these things, unless and until you have to focus on that, may go unnoticed, or may we do not understand what is happening. Then cutaneously, that is a very, very important thing to be noticed, photosensitivity, because I told you the environmental factors, the sun, the ultraviolet light is also very important. So malar rash, oral ulcers, and discoid rash. What are they? We'll further discuss. In hematologically, person can have anemia, leukopenia, lymphopenia, thrombocytopenia, lymphadenopathy. Any of the picture might be there. Now, if you see the neurologically, the cognitive disorders, mood disorders, headache, seizures, mono or even polyneuropathy, stroke or even TIA can be there, present. Now, renal is again very important. If you find a proteinuria of more than 500 milligram in 24 hours, or patient lending into nephrotic syndrome or ESRD, that means end-stage renal disease, they are again important. Pleurisy, pericarditis, effusion, myocarditis, endocarditis, the artery disease, it can manifest anything. GI system, nausea, diarrhea, abnormal liver enzymes. So you see, it is affecting all the organs of the body. The presentation can be anything. Sorry. Just a minute. What is this happening? No. Yes. Yes. So let's go for this. How do we diagnose it? So these clinical features, which can be very varied, not at all confined to one system, but additionally, they have to be confirmed by serological markers. Now, so the American College of Rheumatology has designed a criteria. So, and that is a table I'll just show you, and out of 11, 4 criteria, clinical or lab, must be met to make it the final diagnosis of SLE. Now, this criteria, you might be looking at it is a very difficult one, a very crowded slide, but it is not something like that. We have already discussed is the criteria, the complaints, basically just a description of how the malar rash looks like, how the discoid rash looks like in discoid rash, you have a adherent keratotic scaling and follicular plugging, and the scarring may occur. Skin, otherwise photosensitivity, unusual reaction to sunlight. Oral or nasopharyngeal ulcerations can be, these can be, patient might not tell you, these you have to examine for that. Arthritis, non-erosive type, I told you, maybe involving one, maybe involving two joints. The joints will be swollen, tender, and there will be edematous effusion is there. Then pleuritis can be there, pericarditis can be there. The important thing is renal, persistent proteinuria, 0.5, greater than 0.5 grams per day, or if you don't have a quantitative one, simply 3 plus urine is can be is indicative of. Neurologically, there, sorry, with that there can be the cast also. So whenever you see the urine examination, don't just go for a albumin and the pus cell and RBC. The casts are important. They can be red cell, hemoglobin, granular cast, tubular, mixed. So they have to be noticed. Then in neurological, seizures can be there, psychosis can be there, and hematologically, I've already told you, leukopenia, lymphopenia, thrombocytopenia. The criteria is a leukopenia, it has to be less than 4,000 per cubic millimeter, lymphopenia less than 1,500 per cubic millimeter, and no other drug is being given, offending drug is being given. Thrombocytopenia less than 1 lakh per cubic millimeter, like any the other problems, help, etc. I've told you there have to be 4 criteria, clinical and laboratory. So what are the tests which we will do? Complete blood count, that will show all the pictures which we just now discussed, the lymphopenia, leukopenia, platelet count, urine analysis. So these are the standard tests. But the specific tests which are there about the autoantibodies, they are ANA, antiphospholipid, anti-dsDNA, anti-Smith, anti-Rho, and anti-LAP, etc. Now, basically, just to give you an algorithm how to diagnose. So if there is a symptom complex which is giving you some suspicion of SLE, order the laboratory test. Initially, only 4 simple ANA, we all get them done. Now, everywhere it is available. CBC, platelets, and urine analysis. If all of them come normal, get relief, patient is not of SLE. If the tests are normal, but patient is having symptoms persistent, there you have to repeat the ANA and also do anti-dsDNA and anti-Rho, which are specific for it. Now, if they all come negative, again, this is not SLE, something other problem is there. But if there are some of them or one of them is positive, then you have to think possibly it can be there. Now, if ANA is there, probably it is a definite SLE. The criteria table has to be looked for along with the clinical thing, and the treatment has to be started, which we'll discuss in little later. Now, supposing the ANA is positive, but when we see the criteria, it is less than that. So then it becomes, it is a possible SLE, and we can further observe it. Now, why we are worried? What happens to when the SLE is there, pregnancy? Chances of preeclampsia, 20 to 30% increase in gestational hypertension and preeclampsia. 20% of women may suffer with the pregnancy loss in the index pregnancy, and specifically in those where there is an active renal disease. That's why I was saying it is important. Now, the common causes of the pregnancy termination due to pregnancy, preterm eclampsia, fetal distress and PROM, leading to preterm birth. That's again a problem. FGR, uteroplacental deficiency, neonatal lupus. This is a rare condition, but it may occur in less than 5% of women with SLE. So that we have to realize. The predictors of adverse pregnancy outcome are active maternal disease, nephritis, proteinuria, hypertension, thrombocytopenia, and presence of APLS, especially the lupus anticoagulant. So that they give the situation. Now, population-based study has shown that 20-fold higher rise of the among women with SLE, maternal mortality is there, and the from morbidity, or you can say the high risk complications, they are 3 to 7-fold higher for SLE than the general population. So during pregnancy, what happens to the lupus? Either in 1/3 of the women, it might even improve. In 1/3 of the women, it may remain unchanged. And in 1/3 of the women, it worsens. So the clinical condition that can worsen or flare without warning, that is what the people, it has been seen in the study. Risk of major morbidity during pregnancy, that has been again in a study shown by 7%. And lupus can be life-threatening to both the mother and her fetus. So now again, this opposite of this, what is the influence of pregnancy on SLE? As you see, it is a Th2 mediated disease. So the immune pregnancy related changes are occurring in the pregnancy itself to adapt the fetus as and that it doesn't work as an antigen, and therefore the immunological mechanism may be triggered and the disease might flare up. That's the one thing which can happen. Disease activity at conception and in previous 6 months, both clinical and serological, is a key predictor, not only for obstetric complication, but also it might flare during the pregnancy. And most of these flares are mild to moderate in severity and involve renal, musculoskeletal, and hematological, 3 systems predominantly that we have to remember. So strategies, how to improve the pregnancy outcome. So the first strategy is family planning counseling and semi-structured interviews. The patient female itself and the relatives have to be counseled about the management in this childbearing age group, how that there should be they should be always in touch of rheumatologist. Then secondly, in the pregnancy has to be discouraged in certain clinical scenarios, like when moderate to severe SLE is there, stroke in past 6 months has happened, severe pulmonary hypertension is there, LVEF less than 40% cases, ESRD or HELP syndrome and osteopenia is there. So these are the cases where pregnancy is discouraged. Now, when can it be encouraged? That is, they should conceive when the patient is stable or in a quiescent disease for at least 6 months. And that is for the safety of the mother and the optimal pregnancy outcome. Now, higher level live births have been seen. And these women, every woman should be evaluated for APL, anti-ROSSA and anti-LASSB, so that to assess the risk of miscarriage and neonatal lupus, and we can counsel on the basis of that. Now, switch to pregnancy complications, drugs in pregnancy, because of those certain drugs are not compatible with the pregnancy and then the lactation. So evidence-based safe anti-rheumatic drugs in pregnancy are, now this is a great big list of this. This is given into the books. I would just to give a little bit, the corticosteroids, the sulfasalazine, hydroxychloroquine, azathioprine, and the anti-TNF drugs. Some are not very well studied. They are mainly compatible during the pregnancy and during the lactation. Methotrexate, lefolunomide, the mycophenolate, mofil, and other cyclophosphamide, etc. Even the non-steroidal anti-inflammatory drugs, they are not allowed in pregnancy. They're not, because they're not very safe. So the same situation goes for the lactation also. Now, so during pregnancy, mainly the idea becomes finally that they have to be managed by multidisciplinary scheme. Rheumatologist, obstetrician, fetal medicine physician, all have to be joined together, hence, if they want a good outcome. Disease activity assessment by rheumatologist is performed at baseline and every 4 to 6 weeks to recognize the signs of disease flare or pregnancy as early as possible before, so that they can be controlled. Now, at baseline, the predictive factors for APOs are identified, particular attention to BP, blood count, renal, hepatic function, urine analysis, proteinuria is done, anti-DS antibody and complement C3, C4 are measured every trimester. So this is one thing how you have to deal with these patients monitoring. Now, disease activity, assessing the SLE flares have to be managed. And the primary goal of managing SLE patients during pregnancy is to maintain disease remission and treating disease flares to minimize the effects of maternal disease on pregnancy outcome without harming the fetus. That is the main thing. So for this, we have to measure that the decrease, supposing the C3, C4 levels are decreased from the baseline more than 25% and anti-dsDNA antibodies are increasing, meaning by this patient might be lending towards the preeclampsia and other complications. So one has to become very alert. Then indicators such as new organ involvement, and when you know the known disease manifestations are there, then you have to switch to immunosuppressive medications and to avoid the SLE flares. So when the just sorry, when the how to differentiate this active renal lupus from the PET, that is very my Mr. Tab, just a minute. Have I
You're having some problem?
No, I just missed one slide, so I was thinking.
Yeah.
So the low dose aspirin and pre-eclampsia risk have to be seen. Lupus nephritis, SLE, PLAPS, these are the risk factors which we have to keep in mind. Meta-analysis have shown that the low-dose aspirin prior to 16 weeks of pregnancy, which we are also giving now, so these days recommendation is that before 14 weeks, this can help you in major reduction of the preterm preeclampsia. And this is encouraged in all SLE pregnancies as an effective therapy, because that is a very big danger. And how to differentiate this renal lupus from the PET, that's also a very challenging thing, because the two conditions are usually superimposed. Hypertension, proteinuria, thrombocytopenia, and even renal impairment are at all the features of both. Doubling of the baseline proteinuria is expected into the pregnancy, but if more than that is there, then you might think that it is indicative of either worsening lupus nephritis or PET. So basically, hypertension, uricemia, and abnormal LFT are point more towards the PET. Renal biopsy, which is not like to be not taken ever into the pregnancy, but actually that is the only one which can give you the definitive investigation and appropriate diagnosis. So, but that is not done. So if these the lupus flare and PET cannot be differentiated beyond 24 to 28 weeks. That's what we have to. Sometimes if it is not possible, then we have to terminate the pregnancy very preterm, because we need to give immunosuppression like cyclophosphamide, and which is not compatible in pregnancy. So lastly, the fetal monitoring, because that is again a very, very important thing. Doppler ultrasound, as we do in all high-risk pregnancies, umbilical and uterine arteries in early second trimester, that is 20 to 24 weeks, is helpful for screening of placental insufficiency problems like IUG or preeclampsia. Uterine artery pulsality is a very sensitive and specific test. Umbilical Doppler ultrasound is more accurate to assess the placental functions and showing various levels of impairment, such as all those like absent, reverse diastolic, and anything increased resistance because of the increased resistance. Now, in these patients, now the problem doesn't end with the delivery also. Postpartum surveillance is again equally important, and the rheumatology follow-up both continuation of hydroxyquinone HCQ therapy during the postpartum, at least 2 to 6 weeks. Specific, of course, rheumatologist is the authority to finally decide. And the specific contraceptive measures should be adopted based on the disease activity and thrombotic risk. Always, like certain hormones if we are prescribing, we know that there are chances of thrombotic risk. So we have to take care of that things. So just a final algorithm, women with SLE who wants to become pregnant, first thing is preconceptional counseling and risk stratification. So what we do in preconceptional counseling, identify the risk factors for APO, assess the antibody profile, APL and anti-ROLA antibodies, identify the comorbidities like renal morbidities, renal damages there, assess the organ damage. If severe organ damage is there, discourage the pregnancy. Otherwise, you can allow. Ensure, and then that safe period which we discussed. Ensure pregnancy medication compatibility. So if she's on one drug, change it to the compatible one. Disease activity at this moment has to be assessed. Is it if active, then discourage the pregnancy, and only during the quiescent phase or stabilized phase one should do it. Then patient monitoring during the pregnancy, maternal fetal monitoring should be done by a multidisciplinary team, as we discussed. Monitor disease activity, complements anti-dsDNA, continue or start HCQ, safe medication to control SLE, adjuvant therapy, low dose aspirin, folic acid, and add LMWH if APL or APS are detected. Fetal surveillance with Doppler ultrasound, fetal biometrics. If anti-RO or anti-LA positive, then serial fetal echocardiography has to be done between 16 to 26 weeks, because cardiac problems can be there into the fetus in these cases. So after the pregnancy, this is the actually summary which I'm talking, just revision, or you might be feeling. So the monitor disease activity, continue HCQ in postpartum period, continue the anticoagulation in APL, APS cases, prophylactic dose if no thrombosis, therapeutic if prior thrombosis, and continue for at least 6 weeks, as I told you. Discuss and initiate contraceptive measures, and the same thing, remember those thrombotic high risk, ensure the medication compatibility with the breastfeed also, not only pregnancy. That table which I have shown also shows who are compatible in the breastfeeding. So this is a case report. I actually have taken it from somebody else. Monica, do we have time or should I stop it?
Ma'am, you can complete your case report, ma'am.
Acha, okay.
No
So,
problem. No problem.
okay. So this patient is 32 years. It is not mine. It is I've taken it from someone else. It is just a patient presented at gestational as of 26 weeks, and she was medical history. She was diagnosed case of SLE at the age of 25, and she was being managed on by hydroxychloroquine and intermittent corticosteroid therapy. There was history of lupus nephritis, which was currently in remission. There was also history of Raynaud's phenomena and mild joint pains. That's also a feature of it. Presently, she came from simply routine antenatal care with the complaints of fatigue, joint pain, occasional mild headaches for a few weeks, and no fever, no rash, no significant change in urinary or bladder habits. Patient appears generally all the time. She was feeling fatigued, well nourished, she was well nourished, vital signs were stable, cardiovascular normal, lung feels normal, abdominal fundalite consistent with the gestational age, musculoskeletal system, there was mild tenderness and swelling in the multiple small joints, particularly wrist and knee. Skin, there was nothing, no active rash, but some discoloration over the knuckles, which previously she had a photosensitivity. The patient was experiencing a lupus flare, and close monitoring had to be done. Management was done with the hydroxychloroquine and regular antenatal visits. The multi-specialty team worked with her. As we discussed, patient was also given full education, and these patients do become aware of the problem and they understand the leukopenia. So patient continued to do this. The outcome was good. With diligent monitoring and management, she successfully carried her pregnancy to term and delivering a healthy baby by elective cesarean section. That was because there was a concern of fetal distress. She remained in close follow-up with the rheumatologist postpartumly, and the the message only I wanted to give, that if you take proper care, diagnose in time, take care of the SLE flares, then baby and mother both can be saved. So thank you very much once again for giving me this opportunity, and I hope I've been able to discuss this rare problem and give some message. Thank you.
Yes, it was excellent talk, Kiran madam. You have really covered everything about the beginning from the right from the diagnosis, then how the pregnancy affect on the disease and how the disease affect on the pregnancy. How the SLE incidence has increased and multi-system involvement that causes mother's life in threatening. So everything you have covered in a very well manner. 4 out of 11 criteria has to be there to diagnose standard and specific test, whatever you have explained. Then maternal mortality increases to 24. That is also very much concerned. Preconception counseling has a important role while having the pregnancy, because the pregnancy itself has a effect on the disease, and disease also has the effect on the mother. So when there is no disease that time, or it is a silent disease, that time we can plan about the pregnancy. Then safe drugs which are in the pregnancy has to be used. And basic about it is a multidisciplinary approach, and rheumatologist should be involved, fetal medicine person also involved, or pediatrician should be involved. That is what. And renal lupus and PET, they has to be differentiated for how we can continue the pregnancy till how long, because renal lupus and PET both have the same signs and symptoms. So differentiation is very important. How we can continue till how long we can continue. So thank you very much, madam. You have explained everything in a very nice way. Thank you.
Thank you very much.
Very nice talk, madam. Very nice.
Thank you.
Thank you so much, ma'am. It was a wonderful deliberation on such a very difficult topic of SLE in pregnancy. Obviously, the multidisciplinary approach is the way to move forward. Now, again, we move to next session, which is again very, very important for all the obstetricians to know. On the topic of internal iliac artery ligation, why every obstetrician should master the skill, and who other than with us, Dr. Mitra Saxena ma'am herself, to deliver this talk. I welcome you, ma'am, and to chair her session, we have two chairpersons, Dr. Sujamal Jacob, madam, and Dr. Prasad Halkarnikar, sir. But I think Dr. Sujamal, madam, is stuck up in some emergency and meeting. She is not able to join up with us.
She will join after some time.
Okay, so Dr. Prasad, I'd like to welcome Dr. Prasad Halkarnikar, sir, who is the president of Kolhapur Obs-Gynae Society. And he's again a very senior gynecologist from the city of Kolhapur. May I have his CV, please? Mr. Vishal?
Dr. Vishal, are you there?
Mr. Vishal?
I am here, ma'am.
Yeah.
Please put the CV of Sir Prasad, sir.
Yes. Am I able to? Just a minute. There's some signal issue. Just a minute.
Sir is into private practice for more than 3 decades.
Share the screen, ma'am?
And he has a special area of interest in the field of infertility and vaginal surgeries. I welcome you, sir, for today's session, and I like to request to kindly introduce our esteemed chairperson for today, Dr. Mitra Saxena, ma'am. Over to Prasad,
Manisha.
sir. Yes, ma'am.
Actually, Dr. Monica has already introduced.
Yes, ma'am, you have been already introduced.
It'll be good that Dr. Prasad can share his inputs. I don't mind, because, we should,
Yes, madam.
cut these formalities.
Sure, ma'am.
Yes.
Yeah, अगर अभी भी
First of
बताना
all,
पड़ रहा है तो.
I am thankful to Monica Singh, madam, for inviting and involving our Kolhapur Obstetrics and Gynec Society in this 12th webinar of FOXIP Symbiosis Series. And madam, your topic is very much of importance for day-to-day gynec practice, and especially in PPH cases. And I request you to carry on the lecture.
Yeah, sir, please बोलते रहिए जब तक मैं इसको डाल दूं. Technical glitches भी तो होती है ना.
All this webinar is actually having all the practical difficulties in our practice, especially PPH and this SLE. SLE is a very problematic, and with every pregnancy, the health of woman goes down, and it is always best is the first pregnancy, and we have to give the best chance during first pregnancy only.
So, madam, what we speak on the internal iliac artery dilation.
I just want to know कि मेरा slide दिख रहा है कि नहीं?
Yes, ma'am, it's visible.
दिख रहा है.
थोड़ा ये जो है ना, please give me some time because I have to
Yes, ma'am.
shift I have to make it single so I can read my own slides. Okay, so a very good evening to all of you and welcome to all the learned people who are here as guests and chairpersons and our delegates. Great effort to get people on board, two committees, two societies, and everybody sparing their time for dissemination of good knowledge. So I just really hope that my gala will
Ma'am,
why
is there some network issue, ma'am?
in state of Haryana, and we all know
Ma'am, your voice is breaking in between.
Dr. Neetu, are you there? Dr.
Should I
Manisha,
call,
can you
ma'am?
call?
Yes, ma'am.
Yes,
Yes,
ma'am.
yes.
Yes, ma'am. Contacting madam. Huh.
Yes. I think madam has got somebody to help her with her network. So if madam can,
Yeah.
take help. Mitra ma'am, are you back? Ma'am, you're muted. Mitra ma'am, unmute kar dijiye, please.
Yeah, I actually suddenly the screen went off.
Yeah.
And I was not able to
Ma'am,
share the screen.
Please be comfortable, madam. We are waiting. We are waiting. No problem.
It's again. So we need really great skill to save a life, especially in catastrophic hemorrhage. And also if we are supposed to, we want to save the uterus, even more presence of mind and skilled, surgeon. We all know PPH is the biggest killer. We'd have no doubt about it. Only thing is that, internal iliac ligation, if we all can do cesareans and difficult hysterectomies, I don't think this procedure actually is tough. It's only that we have not been taught in our medical college. And we have been, living with this adage that agar hysterectomy karni aati hai, to what's the need? But, friends, sometimes it's really important that this could be a procedure which could save the life and the uterus of the patient. So what is important is to make the decision timely. And we know what is the indication, the time, the team is prepared. So it's not just I am proficient in doing ligation, I'll be able to do it. The person standing in front of me should equally be well-versed to know how to retract and everything. So I'll try and cover small important learning points in my presentation. We all know this is the journey in trying to save life and patient. All these things are available to us, but what is to be used? That is the million-dollar question, especially when you're dealing with obstetric hemorrhage. Should I do stepwise? Should I do compression? Should I do a hysterectomy straight away? Well, the person who's dealing with the hysterectomy, he or she is the best judge. Unstable patient, anesthetist not very confident, blood not there, then please take the shortest route. All these things are, useful when you have a full team ready. So this is my dynamic team in Practical Obstetrics Committee who have journeyed with me in bringing this presentation together, taking these workshops and all forward. Thanks to all of them. We've done a lot of these things. Most important thing in managing obstetric hemorrhage and internal iliac is teamwork. So some very important, very basic instruments which should now be present in our cesarean section trolley. That is the Devers retractor and a mixed forceps. If you have these two things, Whenever you need it at a time of cesarean section, you can always manage to do internal iliac artery ligation. Your anesthetist should be informed of what you may need. Blood should be ready. Your assistant in front of you should also be a part of your, team, knowing what you are doing, what you want to do. So my learning is that practice it in peacetime so you don't bleed in wartime. And journey of 1,000 miles starts with a single step, and that step could be today or tomorrow. So let's actually learn the insights into decision making and how to master the skill at our own, place. We all know that this is now with increasing cesarean sections, placenta accreta syndrome, ectopic pregnancy, scar ectopic. There are so many increase in indications where we may need to ligate the vessels, decrease the supply to the pelvis, and then carry on whatever we want to do. So I'll be trying. The connection is going off again and again, and it's very disturbing. I'm so sorry.
Madam, the weather is bad in your place.
Yeah, I am there, but the connection is very poor. I don't know why it's always all the time,
Ma'am,
running away.
is there somebody to help you?
So,
Madam, is there somebody to help you?
sorry?
Is there somebody around you who can help with the network?
Am I visible and audible?
Yes, ma'am.
I think I am visible and audible.
Yes, ma'am. Yes, ma'am.
Okay.
I
So
think
basically,
Dr. Mitra, if this connection is weak, video part whenever, can be avoided whenever it is possible. Audio will be then will improve.
Yeah. Madam, it's getting on.
Yes, ma'am. You can continue, Mitra, ma'am. I think ma'am ka first network gaya.
Network is gone.
Actually, I was thinking if somebody can connect madam's personal hotspot of phone. Hotspot of phone can be
Or
connected
if
with
Monica, if she can share her presentation, somebody can run for her.
Yeah,
So
yeah.
that would become
Yes.
more easier.
Manisha, please call madam. If she can,
Okay,
you know,
yeah.
she can WhatsApp her presentation. Mail तो होती नहीं है. WhatsApp हो जाएगी.
no, actually, वो जाएगा नहीं. The slideshow has got all the videos, so it's very difficult to share. Otherwise, I would have shared. It'll take a lot of time. I don't know why.
You are visible now, madam.
Okay, I'll
Hello, Mitra ma'am. Neetu, please call madam again.
Ma'am is in line with me. She wants the Mr. Vishal. Can you unmute, ma'am? She is
हो
not
गया
able
हो
to
गया
unmute herself.
अभी हो गया अभी हो गया
Okay, ma'am. Okay.
आप बता देना और अगर ज्यादा हो तो फिर डिलीट कर देना बिकॉज आई डोंट वांट टू वेस्ट द टाइम
Ma'am,
ठीक
we
है
can hear you.
Ma'am, we have
Okay,
ample
thank
time. Ma'am, we have time till 8 o'clock. आप मैम आप आराम से करिए मैम.
I'll keep my video off, and if I go off again, then just delete it. Maybe some other time, Monica, I'll do it because net connection is very poor. Anyhow, friends, so very important thing to learn is the S1, S2 segment concept of the blood supply of the pelvic organs. So this is really, really important because this is what will help us in decision making. We have to remember that the upper segment is supplied by uterine artery 90% and 10% by the ovarian artery. And both have different origins. Ovarian is a branch of aorta, whereas uterine artery is a branch of internal iliac artery. Now, the S2 segment, or which is the lower segment, that is supplied by branches of uterine, cervical, upper vesical, vaginal, and pudendal arteries. So here it is important that the S2 segment, if there is any vaginal vault tear, vault rhexis, so you cannot ligate uterine artery and achieve hemostasis. Here, if you ligate the internal iliac artery, you'll be able to decrease the pulse pressure and control the bleeding and even repair the tears. So I thought that this is really important to learn. अभी आगे नहीं जा रहा. So sorry, this is not moving now.
मैम वो बॉक्स आ रहे हैं आप कंटिन्यूअसली प्रेस करिए.
अब ठीक है अब ठीक है
Yes,
yes,
ma'am. Yes,
आ
ma'am.
रहा है, move करा है.
Okay. So this is very important to remember. A little bit of anatomy I will share before we go on to the actual learning. We have to remember that aorta bifurcates at level of L4 in the abdomen, and it divides into common iliac artery, right and left, and both of it descend in the pelvis, and at the level of sacroiliac joint, again common iliac artery bifurcates into external iliac and internal iliac. What is interesting is that in a living patient, all these vessels can be traced right from L4 aorta, then the major bifurcations. Then in the pelvis, you can easily palpate the external iliac artery and the internal iliac artery and identify these vessels by the bifurcations. Why I say the bifurcations are very important. I mean, like in a living body, it's not that they're so distant apart. They can be very close to each other. So you have to be, deft at recognizing that these are pulsatile vessels. Start palpating them, exteriorizing uterus after an elective case of abdominal hysterectomy or a cesarean, and then palpate the aorta, the common iliac, and the external and the internal iliac. Very easy to identify the external iliac. It will be lying on the psoas muscle. And if you press the femoral artery of your side, the external iliac pulsation will be gone. So these are little tips to know how to recognize the external iliac from the internal iliac. This is just simple palpation. Of course, when we have to ligate the vessel, we have to expose the vessel and we have to pass the mixture. So basically, we all know that the internal iliac is the major blood supply of the vessels, and we are wanting to ligate the anterior division of the internal iliac artery. We all know that the posterior division actually supplies the gluteal region and the lower back. So the posterior division, the iliolumbar, the sacral, and the superior gluteal. So this is one bifurcation, the bifurcation of the common iliac. Second bifurcation is the external and the internal iliac. And the third bifurcation is the posterior division and the anterior division. This is a very nice diagram and you can take a screenshot. So this is the anterior division and we have to ligate it after its bifurcation. Posterior division takes its position from posterior aspect of the artery. So it doesn't actually interfere. We only have to go beyond this bifurcation and then ligate the anterior division. And that will take care of the vessels of the inferior gluteal and the internal pudendal. That could be the reasons for the S2 segment bleed. Now, this is again a very, very important key diagram. If we look at the course of the ureter, we'll realize that ureter is our friend. It leads us to the internal iliac. So here is the sacroiliac joint where the ureter will be descending into the pelvis. This is the external iliac. It will be overlying the internal iliac. So just keep following the ureter and you'll be able to be on top of the internal line. And then after, around 4-5 centimeters from its origin, you have to find that place, dissect it and ligate it. So external, we have to know the relationship. External iliac is the most lateral, then the external iliac vein, then internal iliac artery and internal iliac vein. And ureter is in the, if we remember this key diagram, this diagram and this diagram, it's not difficult to find it in a living person. Now we have to understand what does the both bilateral ligation of internal iliac artery do. It decreases the pulse pressure. Actually, it doesn't decrease the blood supply totally. It decreases the blood flow by 50% and decreases the pulse pressure. So the arterial, trip hammer effect is gone, and it's a low pressure venous flow. So there, the clot will form and it will actually help in arresting the hemorrhage. So we have to know that the indication of the patient where we do it, it should be appropriate. Suppose we have a patient of atonic PPH and not controlled with uterine artery ligation or bilateral uterine, bilateral ovarian, then you may think of ligating the internal iliac artery. If your patient is stable enough. Again, in cases of rupture or broad ligament hematoma, abruptio, all these things, especially most important thing is that the patient should be stable with a normal coagulation profile. Now, this is extremely important to realize that in our patient who's bleeding profusely and who's receiving crystalloids, she may have dilution and she may already be in a coagulopathic state. So we have to understand that whatever decision we take in arresting hemorrhage, it has to be quick, swift, and appropriate. That is the most important thing. And pre-diagnosed cases of placenta ecreta syndrome, you don't have methods for doing these fancy things with interventional radiologists, then this is a low cost skilled procedure where you do the ligation first and then you deal with the hysterectomy. So this is extremely important because with the rising cesarean, we are getting rising incidence of placenta ecreta. So now I'm going to skip some of the slides. So this is the 5 key steps of internal iliac artery ligation. So basically, we know that the vessels are in the retroperitoneum. So we have to reach the retroperitoneum either through anterior or posterior approach, dissect the pararectal space, identify the anatomy, keep the ureter in the medial flap, identify the bifurcations as I told you, isolate the internal iliac artery, which will be going down deep into the pelvis. How to identify internal is rule out the external iliac artery. So the other one is the internal iliac artery. And dissection parallel to the vessels. So we know that the internal iliac artery has the internal iliac vein, posterior medial. So we have to find the groove between the vessels and dissect parallel to vessels, not across. So just work there, make fenestrations, and then pass a mixture lateral to medial side and tie the loop of thread. So basically, you can do these key steps step by step. It's not in one day you'll learn everything. For a couple of 5 or 7 cases, just palpate the vessels. 5 to 7 cases, just open the retroperitoneum, identify external iliac, identify internal iliac, palpate, just go beyond the bifurcation and look at the place. The next 5 cases, dissect the vessel, make the fenestrations. Next 5 times, pass the mixture. So if you've done this exercise, I'm sure in times of emergency, you'll be confident to pass the ligature yourself. The best thing to do is have a good trusted friend like Monica has Pragati and I have Renu. All of us have our, soul friends who will be with us in times of distress. So my big lesson is that we should learn it in pairs. So whether it's your surgeon friend in the same city or a good obstetrician, learn it and practice it and be ready for the emergency. I will share with you all. I hope that the video transmission is good. Please let me know. This video has been prepared by Dr. Manju Pune. It's beautiful. And this is in an elective case. So you'll be able to see almost everything. To just set the position right, On the right side is right side of the patient and left is the left. So this is the left-sided round ligament which has been held by Babcock. Now this is the anterior thing. This is the tube. This is the ovarian ligament. And now we hold the round ligament and hold the peritoneum out beyond the round ligament. Between two hemostats, we open the retroperitoneum. What important thing is that there are no tributaries or vessels within the prerectal space. So this is the, opening the retroperitoneum. So go in the, if you go from anterior aspect, you have to go craniocaudally. You remember that we have to go up to the bifurcations. So go cranially, and the other landmark basically is also the infundibulopelvic ligament, because we have to remember our anatomy. Somebody tell me that, are you able to see this beautiful video? Manisha, Monica?
Yes,
Dr.
ma'am.
Mitra, we are able
Yes.
to see.
Yes, ma'am. Very
Thank
touching.
God. Thank God.
Very nice video.
Basically, very beautiful, gentle finger dissection is to be done cranially, and you'll see how deftly the devers is placed, and very soon, see, we have to know how will we recognize the external iliac artery. Now, the external iliac artery would be overlying the psoas, and why I showed you the initial diagrams was so that you have a general idea where to find the psoas muscle. So you go cranially towards the pelvic brim, you will be able to find the psoas. And here now, abhi apan ko nahi dikh raha hai because she is doing it with the suction tape. But once you are doing it yourself, you'll be able to palpate the vessel, which is pulsating. So it's very easy to identify the external iliac artery overlying the psoas, and our ureter is our friend. So we'll understand this is actually, so here, this is the external iliac artery, and the ureter is here. You give a push to the ureter will show the peristalsis. This is the psoas muscle. You can see the belly of the muscle. This is the ureter. The peritoneum over the ureter, and it gives the peristalsis. So here is the bifurcation of the common iliac. So this is the external iliac artery. This is the internal iliac artery. Can you see the bifurcation? This is the psoas muscle, external iliac artery, internal iliac artery, and the ureter in the medial flap. Now the thing is this, that this is the internal iliac artery. So once you see the internal iliac artery, you have to work vertically, parallel to the vessels, not across. So groove may just identify the adventitious tissue and cut it. This is the bifurcation. You can see very beautifully the bifurcation. So,
And would you prefer dissection from the ipsilateral side or contralateral side?
sorry?
Dissecting from the ipsilateral side or the contralateral side?
Left side. We are showing the left side.
Yeah.
See, that's why I said this is the external iliac artery. And see how the sheath of the vessels is cut. It is like this. ये vessel है ना, तो इधर इधर काटना है, इधर इस शीथ को जो वेसल्स को कवर करती है उसको काटना है, इधर काटना है, इधर इधर फेनेस्ट्रेशन बनाने, फिर लैटरल टू मीडियल यहाँ से इधर डालना है. देखा, ये रहा एक फेनेस्ट्रेशन, ये दूसरा जेंटली लैटरल टू मीडियल डालना है. दैट्स इट. इतनी कहानी है सब. And very gentle. पीछे is the vein. Vein is thin walled. Artery नहीं puncture होती. It's the vein which has to be taken. And we have to be very gentle. Here you can actually even use a little scissors or a blade to snip it off and allow your mixture to pass. ये सिर्फ sheath वो है, adventitious tissue है covering the vessels. So this is the artery. And see, the thing is this, you have to apply the devers आमने सामने. So your assistant has to know. ये left side है, ये right side है. Lateral to medial. That's about all. This is all. And when you did it from anterior aspect, you have to go up towards the brim. Now, I will show you. This is posterior aspect. Now orient yourself. This is the posterior aspect of the uterus. This is the right side of the patient. Are you with me? Can you
Yes, ma'am. Yes, ma'am.
figure it
Yes,
out?
ma'am.
This is the posterior aspect. This is the uterosacrals. This is
Yes.
the beautiful ureter. Here
Yes.
is the diverts. So the uterus has been exteriorized, and now I will start the film. So, wait one second. Wait a second. I'll have to just. So again, this is the uterosacral and this is the ureter. So, madam is going to hold the ureter in a Babcock. Now, this is the posterior approach. So, we are opening the retroperitoneum from posterior aspect. So, very nicely, again, the retroperitoneum is opened. Always remember that we have to go cranially because our bifurcations of external iliac artery and internal iliac is at the brim, close to the psoas muscle.
Yes,
Okay, now, again, you have to go up 5 to 6 centimeters, open it, and there is nothing. Use of your own fingers gently or a suction tip is all that is needed. बाकी सब कुछ उंगलियों से कर लो and don't try to be very conjuice in the dissections. So you can easily see that this is the medial flap. This is the medial flap and our ureter is here in this medial flap. So how this is extended up and down. And we have to understand that we'll find the leash of vessels of this. This is infundibulopelvic ligament actually. क्योंकि ये close to brim है. अभी इसी के पास we'll be able to find the psoas muscle. So don't injure this pedicle at all. ये ureter is now behind this medial flap. Open the peritoneum slightly more and gently retract this ligament. And then we'll be able to see the psoas. Can you see this is the psoas and this is the genitofemoral now?
Yes, ma'am. Yes, ma'am.
Abhi, the beauty is that when you're doing these dissections, you can always feel. हमें देखने में वो लगेगा ये वेसल है, बट हम जब पैल्पेट करेंगे तो वो मसल होगा.
क्या?
Here you can see.
Measles? ग्राम पे होगा.
So this is the internal iliac
चौथे साल
artery.
को.
This is the external iliac artery, and these are the fenestrations already made. ये थोड़ा edited है video. This is how the sheath will be dissected parallel to the vessel. This is what is to be learnt. And then mixture will be passed from lateral to medial side. So basically, this is somewhere here, the bifurcation of common iliac is somewhere here under the divers, and this is external iliac, this is the internal iliac. Beyond the bifurcation, here is the bifurcation. So from here, you pass the mixture lateral to medial side. This is lateral side, this is medial side.
Yes.
So it's not difficult actually if you do this in peacetime. And don't do it in the first case only. थोड़े में तो सिर्फ palpate करो और open करो और देख लो vessels को, नमस्ते करके आ जाओ. फिर dissect करके 2-3 में dissect करके देख लो और फिर 2-3 में just pass the suture. See here again you can just cut it, snip it off with sharp scissors or scalpel, and so that your mixture does not cause injury. Now see there, so the thread is already preloaded. Ideally we can pass the mixture and then load the thread, but here they have already preloaded the thread, so never mind. We have double loop so we can leg it. So this is about all actually. So basically it's not difficult. Ureter is very much there by God, given by God for us to recognize the internal iliac artery. Just like see how beautiful this is the ureter, and we could see the bifurcation. So I think I am so grateful that at least we were able to show the videos. Monica,
Yes,
was
ma'am.
it
Very
visible?
beautifully visible.
Beautiful, ma'am. Beautiful videos.
Thank
The
God.
videos are
Thanks
waiting.
to the
Details were
internet.
visible.
Sorry? Thanks to Manisha, she told me switch off your video, things will be better. Anyhow, so we have to understand that nothing is perfect. It has its limitations. There could be nerve injury. You could ligate the wrong vessel, especially when the patient is in shock and you cannot make out, you don't have the advantage of having good pulsations. So in any case, I would not recommend a new learner to take up heroic cases, do show heroism early. This is to learn in peacetime, and of course, when you are, dealing with more difficult cases, this could be a problem that you ligate the wrong vessel. And if you already prolonged the operative time, your decision has become, you've taken the decision later than earlier, then you may miss the bus. So basically, you have to know when to do it. If you know this method, you can use it appropriately. And of course, placenta accreta syndrome, I think everybody would have seen them now in this present scenario. So I think, there electively, after you've delivered the baby through upper segment, not removed the placenta, stitched up the uterus, then you externalize the uterus and then go ahead and ligate the vessels and then go ahead with the hysterectomy. So that is really, really very helpful. So my aim of doing these talks is, confidence building, that from I can't do it to I can do it. And you would have seen it's not rocket science. It's just that we were not oriented in our PG times. Throughout our careers, we were very smart and happy with doing only the hysterectomies. But never mind, I want to tell you, just take a screenshot. I have this, actually this slide summarizes everything about the internal iliac artery, how to find it and how to ligate it. All the steps are written beautifully over here. And of course, we need good assistance, lights, Devers retractors, mixed forceps, and good anesthetists and blood supply. Now, I don't know, Monica, if there is time, I can show the cadaveric dissection. Otherwise,
Yes,
we
ma'am.
can go.
Please, ma'am, we are waiting for it. Please go ahead,
Okay,
ma'am.
you want to see? Well,
Yes,
this
ma'am.
is the cadaveric dissection Dr. Savita Singhal and myself went and did in Medical College, Rohtak. That's my alma mater. And Dr. Savita, a part of my, team, is my junior. So you will realize that, going through the cadaver, this is anterior part. That is the head end of the patient. This is the foot end of the cadaver. This is the bladder. This is the uterus. And this is the retroperitoneum. This is the fallopian tube. So basically, in a cadaver, things are not that, the tissues are not supple. I've already shown you the best film. That is the living tissue. But here the thing is this, that whenever you have the opportunity to go and dissect, you're not afraid. You can nicely take your time in recognizing. So see, this is anterior approach and we've actually opened the retroperitoneum. But you'll see that actually we had difficulty in finding the ureter and the bifurcations in a cadaver. Here you can see, basically, because this is the vein, external iliac vein, this is the external iliac artery, this is the internal iliac artery, and the ureter was very thin. So, in fact, cadaver में recognize करना इतना आसान नहीं था जितना कि लिविंग टिश्यू में था. बट हियर यू हैव द लिबर्टी की आराम से देखते रहो और जाओ, पूरा का पूरा ही स्टडी कर लो. हैव अ लुक एट द psoas, genitofemoral nerve, and see, now you can see very nicely, this is the external iliac artery, this is the internal iliac artery, these are the branches. ये bifurcation दिख रहा है आपको. So basically we prepared this video so that we can show the how it is in a cadaver. So any one of you who has the liberty to go into a medical college and the anatomy department, please go and dissect and look at the structures yourself. That is just for confidence building. So and of course, the same procedure, how to do the dissection of the vessel and then pass the mixture, the thread and the mixture forceps. So basically, this was so that in case we are not able to have in our workshops, if we don't have cadaver, we can show what cadaveric structures look like. Okay, so that is about all. And of course, if you look at angiographically, this has been presented by Dr. Farendra Bhardwaj in my online meeting. And then also I had asked him to do the laparoscopic tracing of the, vessels. So again, if you have time, I can show you that.
Yes, ma'am.
Should I
Please,
show
ma'am.
you?
Yes, ma'am. Yes, ma'am.
Monica
Yes,
सब
ma'am.
दिखवाएगी है. Okay, so again, इन्होंने पूरा पीछे से करके दिखाया है, and all in the audience who are doing laparoscopy, see, you can recognize this is the ureter through the retroperitoneum, and just open the retroperitoneum. Of course, with excellent energy sources, you can keep opening the vessels, and it's very simple to recognize all the tissues in laparoscopy. और यहाँ पर ये advantage है कि you can see all the branches in laparoscopically, especially the first branch of the in anterior division is the obliterated umbilical vessel, है ना, और उसके बाद uterine artery है. All the laparoscopic surgeons are very well versed in finding uterine artery at origin. So here, see, you can easily make out the psoas muscle. So the external iliac will be overlying that. This is the internal iliac vessel, which is our vessel of importance. And here, laparoscopically, it's very easy to dissect atraumatically, basically. So you can, this is the ureter, external iliac, internal iliac, and then all the branches actually he tried to show. But I'm just trying to show you that whether you do it laparoscopically or you do it open, it's not difficult. Just identify and keep ureter as your guide. This is the external iliac, this is the internal iliac, and all the branches. Posterior division जो है वो posterior aspect से निकलेगी, तो आपको यहाँ पर ligate करना है. How beautifully this has been done, thanks to Dr. Farendra. Okay, so now what are the complications which can be faced during internal iliac? So you have difficulty in assessing the desired site. Suppose the patient is very obese, so it may not be so easy to recognize the vessels, and ligating the wrong vessels, injury to veins, injury to neighbor structures, ischemic damage. There could be anatomical variations and some remote and rare complications. What is extremely, extremely important is the consent, preoperative, intraoperative, and what should be explained. Why I share again is that in 2011, I had to help two of my colleagues in managing obstetric hemorrhage, and it was vault tear and broad ligament hematoma. In both the cases, we did hysterectomy, and in one of the cases, I had to suffer an FIR because they said कि तुमने तो सिर्फ 2 blood लगाए और uterus निकाल दिया. You should have saved the uterus. Of course, I got saved because we were two gynecologists. I being senior, I was harassed. So from that time, it was in my mind that had I known internal iliac, maybe I would have tried. Of course, at that point of time, I thought I'm doing the fantastic job of doing a saving the life. So basically, what are you supposed to tell? So whatever you do, whatever you don't do and why you don't do also has to be mentioned. This is very important. So even if you do hysterectomy, but you could not do any, uterus saving procedure, just write it. Because in court of law and the lawyers and those who want to harass you, it's better that we just don't bank on our vital signs. Of course, in my notes, the pulse was 140, blood pressure was 70. It was, evident enough that the patient was in shock, so hysterectomy was a wise decision. But I think that in hindsight, if I had written that the patient's vital signs did not allow me to try any, procedure of internal iliac, so decisive action of hysterectomy was done. So maybe it's more, it will save us more if we are more clear in what to document. So these are all the salient points which should be mentioned in the documentation. Name of the surgeon, what is the indication, Why was internalized? Because you can be caught. They can tell you तुमने internalize क्यों किया, तुमने hysterectomy क्यों नहीं की. You do hysterectomy, they'll say तुमने hysterectomy क्यों करी, तुमने internalize क्यों नहीं करा. So you have to justify whatever you do. You do a hysterectomy, justify it. You do a ligation, you justify it. Whatever it is, just write it very clearly and describe the vitals before and after. Also that you have checked the femoral pulse after the ligation. You have visualized no damage has happened. So everything in this slide is very important. And when can we fail is, of course, if there is delay in our decision because of dilution, we have coagulopathy. And of course, we have to remember that the, what do you say, collaterals are so many. If you delay in your decisions, by the time you finish off the ligation, the recirculation would have happened within half an hour. So you have to be very quick and swift in taking your decisions. So my, my aim is that everyone who sees it, who listens to it, they should be inspired. And it is very much possible to learn it at our own center, in our own, with our own cases. Use your stereognosis, palpate and touch, and remember they are all pulsating vessels. Visualize it, open the retroperitoneum, look at our ureter, keep it in the medial flap, and then identify the vessel and then mark where you have to pass the ligature, dissect the sheath, denude the vessel from the sheath and pass the mixture lateral to medial, and never miss the opportunity to go back to the dissection hall. Most often it is fear, fatigue, and failure to judge that we resort to, we are in trouble. So my learning has been that whenever it is indicated, because of these continued workshops, I'm happy to say in year 2022, November, 4th November, I was able to save my own patient's uterus and her life. It was a very bad vault tear. She was bleeding profusely. We couldn't, just packed her up and shifted her to the OT, took the internal ligation first, then came on to the perineal side, nicely repaired the vault tears, and then pack her and leave her and manage her comfortably and save the patient. So basically, if you take the right decision at the right time, you will be in the right place. Thank you so much. Thank you, Monica. Thank you, all of you. I'm so sorry that I was not up to my,
Madam, you were so passionately speaking about this topic that all your voice, everything became okay.
Yeah.
We really enjoyed the
Sorry.
session.
Yeah.
I hope you all could see the dissection. It's really
I can
beautiful.
see and listen to you both.
Ma'am, it was so mesmerizing. It
Yes,
really,
ma'am.
and it has motivated all of us to, go to the dissection hall and do one step
Don't
at
go
a
to the dissection hall. I mean, like, of course, go to dissection hall if you can, but don't wait. अपना
Yeah.
abdominal hysterectomy कोई ना कोई laparoscopy मत करो. Abdominal को लो, अपने best friend को साथ बुला लो, and Pragati will agree with me कि it's
Yes, ma'am.
not so difficult.
बराबर
Right.
है.
So
Yes.
just look at the vessel, open the retroperitoneum, open the sheath, and just pass the ligature. I can't even tell you, it seems so incredible, but maybe a month ago, one of my junior friends from a distant place, she called me up in the middle of the night and she said, "Madam, मेरा patient bleed कर रहा है और मैं internal ligate करना चाहती हूँ." तो मैंने कहा, "तू एक surgeon बुला ले और फिर करती चल." So just, जैसे मतलब शब्द भेदी बांध नहीं होता, I kept telling her, अब ये देख, ये देख, ये देख. And she was able to ligate the vessel because she had seen all these videos on the online and all that. So, it's not actually difficult, but of course, I wouldn't take the
Yeah.
decision in
It is
emergency.
not
Learn
that
on the
difficult. It is not difficult, but when patient is in PPH and when it's bleeding profusely and patient is hypertension, it is really a matter of great, great experience that you can do intercalec. If you are not well versed, definitely resort to some other way, take the help.
Yeah,
Go for hysterectomy
definitely.
if you are better in hysterectomy, but save the patient. That is better. But
Of course, that
course,
is why I have shown these videos, that these
yeah, very
videos
nice.
have been prepared for teaching. So they have been
Yeah.
done in elective cases. So you can take out one or your two elective cases of cesarean, breech, primi, आप उसमें वेसल्स तो देख ही सकते हो ना, कोई आपको पकड़ तो नहीं सकता। अपनी टीम बना लो और जिसके साथ करना
एक
है,
कंप्रेशन
हाँ,
कंप्रेशन
एओर्टिक कंप्रेशन कर दो,
करके रख
because
दो
there are
कि द
so
हेल्प
many
कर रहा है.
ways to arrest hemorrhage, and every little knowledge helps you in saving the patient, saving the uterus, saving yourself. Thank you so much, Monica. Thank you, everybody.
Personally, which approach do you think is easier for the beginner? Posterior approach or anterior approach? Ma'am,
listen you.
Ma'am, muted. Ma'am, you're muted. Mitra, ma'am, you're muted.
अरे, मैंने अपना जो पेशेंट था ना, वो पतली सी पेशेंट थी, राइट साइड तो मैंने एंटीरियर अप्रोच कर लिया बड़े आसानी से। हमें लगता है कि लेफ्ट साइड में सिग्मॉइड कोलन है, मुश्किल होगा, बट ऑन द लेफ्ट साइड आई फाउंड द यूरेटरी रेक्सटराइज करके मैंने पोस्टीरियर अप्रोच से किया। तो मैंने अपने पेशेंट में दोनों अप्रोचेस से खोल के देख लिया। शी वॉज इन शॉक। वो तो 160 उसका हार्ट रेट था, बट अभी तो इतना देख लिया, कर लिया, लोगों को सिखा लिया, पढ़ा लिया कि आई हैड द थिंग कि ये बच जाएगा यूट्रस भी और हम कर ले जाएंगे। बट ऑफ कोर्स आई हैड माय टीममेट्स विद मी, सो वी वर नॉट डूइंग इट नोविस, पहली बार नहीं कर रहे थे। तो वो, पर ऑफ कोर्स ऐसे टाइम में वीडियोस बनाना तो बहुत मुश्किल है, बट यस, पीस टाइम में तो सीख ही सकते हैं।
What excellent job you have done as chairperson of Practical Obstetrics Committee, and you're still doing, ma'am. And we are so lucky to have had you in this session. I mean, it was really a very, very good session, ma'am. And now I think we have a lot of things to catch on in the forthcoming panel. And I think Kiran ma'am's next talk is also in continuation with your procedure, your description, ma'am. Thank you. Thank you so much, Mitra ma'am.
Thank you,
Thank
Mitra
you.
ma'am. You're truly speaking from
Prasad
your
sir,
Thank you,
heart.
madam.
Prasad sir, you would like to speak something, sir? Prasad sir?
Malik,
Yeah, it was a very nice presentation,
Malik,
and especially the videos are quite guiding, and it has helped us to elevate our fear about the anterior branch of internal iliac artery ligation. Thank you, madam.
Thank you, sir. Thank you so much.
Thank you so much, Mitra ma'am, for such a wonderful talk. You were truly speaking from the heart, and I think our delegates really had a treat today. Again, very important topic next, from directly from the committee chairperson, Dr. Kiran Pandey ma'am, peripartum hysterectomy. And to take this session, I'd like to request Dr. Neetu Mishra to please take the session further ahead. Dr. Neetu Mishra.
Thank you, ma'am. I am honored to introduce our chairperson for this session, Dr. Archana M. Dwivedi, ma'am. She is currently the president of Baroda OBGYN Society and national chairperson IMS Website Committee 23-25. Ma'am has also been the president of Baroda OBGYN Society in 21-22 when this
I think,
society...
we will not waste much time. Just my appeal to support me for Midlife Management Committee and Monica as Spectacle. That would be our best introduction for now. I think we should...
We fully support you, ma'am, for your upcoming elections.
We should
And
not
all the best,
in
ma'am.
the great talk we are looking forward to. I could, from preserve the uterus, the internal ligation, I would thank Monica from the core of my heart that seeing such a beautiful, mesmerizing was the right word which you used from Dr. Mitra madam. And now going over to Dr. Kiran Pandey madam, yet another epitome of strength when we talk about obstetrics, and I'm seeing her with the Menopause Society also so much active. So now going to the peripartum hysterectomy, which is a need of our, I think madam will be talking about, with increased incidence of past syndromes, and PPH is always a nightmare. I think we would like to hear you, Kiran ma'am, straight away without wasting time and being rewarded to be in this webinar.
Thank you, Dr. Archana. I know we have already been, I mean, it was such a wonderful listening to Dr. Mitra. I was feeling like the same time as a teacher, I have been explaining to the students in the same way. So it was just like looking that the way, same way she was making it very clear step by step. So, Mitra, it was a great talk, and with I mean, you're not feeling well, but still, as Dr. Monica said, being so passionate, you did a good job. So let's start with the those cases where you are not able to do internal iliac artery ligation, or some you're not at a good center, or you've not done earlier. So in that crisis, it becomes, as Dr. Pragati was saying, sometimes hysterectomy is also still, we should do what we are best, because the ultimate aim is to save the patient. And so that's why, let me share my screen, and let me, yeah. So I hope we are able to see the my screen. Hello?
Yes,
Am
ma'am.
I?
Yes,
Yeah.
yes.
So, okay, so now let's start with this. Yeah. So with this background, already we have discussed so much. So emergency peripartum hysterectomy. Now what it is, how it is defined, as I'm fond of this starting with that it is performed either immediately or within 24 hours or any time from delivery to discharge from same hospitalization. So remember it, not only at the visit, but within 24 hours or even before discharge. This is called, totally all of them included into emergency peripartum hysterectomy. The most dramatic operation, naturally, when all the conservative methods, measures have failed, patient is such a young patient, and her obstetric career is going to end here. But unfortunately, sometimes to save the life of the patient, we have to do this because we have not been able to achieve the hemostasis. So saving life is more important than saving uterus. That's the motto, as we should remember at the back. Now, another complicated part of this is it is an unplanned surgery, and we have to also perform it expeditiously because the patient's vitals are already shaky. She's lost blood in that moment when we were trying to conserve it. So that acute loss of blood renders the patient in a less than ideal condition to go for emergency surgical intervention. That's one of the, you can say, the most difficult operation in these days, especially in cases of the past. Now that has become a very important thing. Now, emergency hysterectomy, cesarean hysterectomy is actually not as the because of the different conservative measures, the stepwise devascularization, the uterine artery ligation, the internal iliac artery, that in the postpartum hemorrhage, the role has become that way less. But because of the increasing incidence of the PAS, still its role is there. That becomes the thing. So its incidence varies from 0.2 to 5.4 in 1,000 deliveries, and the higher incidence reported always in the developing world than the developed countries, and incidence from vaginal delivery remains almost consistent, 0.1 to 0.3. It is because the factors remain, the risk factors remain the same. But after cesarean section, as I told you, because of the past, the incidence varies long, 0.17 to 8.7. And that is attributed to placenta previa and placenta accreta. The reason becomes. Now, in the developing world, preventable factor like uterine rupture, uterine atony is the most common. Whereas in the developed world, morbidly adherent placenta has replaced it. Now, I feel when I was writing this sentence, I thought ki in India, both the things, we are sometimes at one places, we are part of the developing world because still the uterine atony and uterine rupture, we do face it. And on the other world, we are also facing the condition of morbidly adherent placenta like the developed world. So probably we are facing both the complications. And obviously, hemorrhage is the most common. So risk factors are placenta previa, previous cesarean sections, multiple pregnancy has a 6-fold increased risk of EPH. The other factors like uterine atony, laceration of uterine vessels, extension of cervical tear in cases like prolonged labor patient has been or in obstructive labor, retained products of conception, precipitate of prolonged labor, fetal macrosomia or maternal obesity, multiparity, previous primary postpartum hemorrhage, that also becomes a risk factor, coagulopathies and choriomnitis. This now becomes very vulnerable. Basically, total hysterectomy is the recommended surgical method. And because the potential risk of malignancy developing in the cervical stent, the need for regular cytology, bleeding or discharge, which is associated with the residual cervical stump. These are the reasons why we prefer the total hysterectomy as an ideal. But supposing we want a shorter operating time, less blood loss, less urological injury, and or the surgeon feels there is no time to go so deep, then subtotal hysterectomy is technically easier. But remember one important thing. Supposing the placenta previa you are doing, or the placenta is adhered into the lower uterine segment, which is a passive segment, or the going up to the os, then we cannot go, we save the patient or obtain complete hemostasis by subtotal hysterectomy, because that lower segment will keep on bleeding. So there somehow we have to make it a total hysterectomy only then the bleeding can be controlled. So the main advantage, of course, of total hysterectomy is also no risk of cancer of cervical stump, which is also very many cases we have seen. Now, the planning and preparation is tertiary care center has to be there. Obstetrician has to be very experienced, senior. Like what happens usually sometimes even in the medical colleges, the emergency time, something is happening, the residents are allowed to do it, but that's not the right way. They can do it, they should do it, but in the under the guidance of the seniors, that has to be done. So the senior has to be there, then one can allow and one can guide totally. So the senior anesthetist, urologist, and vascular surgeon are also important. If any vessel injury, they really help us. Blood bank with enough blood products, massive transfusion protocol has to be initiated, specifically when you are doing hysterectomy for PAS. ICU with ventilator facilities and expert intensivists have to be informed that we might need an ICU. The counseling part, decision making, need of ICU, future fertility, and decision to perform hysterectomy, that which is very difficult in a nulliparous woman, as this brings an abrupt and unwelcome end to the reproductive careers. So as just before me, Dr. Mitra was talking, their counseling becomes very important, their consent becomes very important. Every point has to be written in great detail, and all the complete documentation, the reason why we are planning this has to be done. So central line, 2 large bore IV cannulas, catheterization, of course, urethric, and sometimes even ureteric catheterization may be needed in case of PAS. For that, urologist helps you, friend will be there. Now, the key principles during surgery are clamp, cut, and drop. Clamp, cut, and drop, meaning by no ligation. Initially, clamping the uterine blood supply takes the precedence over any adenoids, packing, clearing, etc. So it should be applied as close possible to the uterus. Excessive tissue should not be included. Pedicles are rapidly clamped, cut, and dropped. Sutured later. That's the important thing. You can apply even 3 clamp, but personally, if I say, sometimes I do need apply 3 clamps, 1 on the medial side because that part is going to be removed, the 2 on the lateral side. If one by any chance gets little slipped from its position, the another one is there because we are not ligating it. So every attempt should be made to identify the ureter, of course, to avoid ligating, keep sufficient stump so that one can ligate it properly. It is an emergency, friends, but not a race. That's what is very important. So be slow to be fast. That's a very, very important point. It's a contradictory statement, but it is a very important statement that you have to be slow to be fast, because ultimately if you're doing too fast and not realizing where the ureter has gone and where the other things have gone, then later on you will waste time in finding out and reopening and all that thing. So one has to be very careful at every step. That's very, very important. Now this diagram you have already, this photo you have seen when Dr. Mitra has shown when to ligate, just that only. The most important the points are, you can see this is uretero-ovarian anastomosis, this is the ascending branch, and this is the descending branch, and there is another branch which is coming and ligating vaginal artery. So here again, there is anastomosis. So all these 4 sites have to be clamped and sutured, so only then the bleeding you can control it. And this where the normally in the subtotal where you are applying the clamp, that is the position. Bleeding have to be controlled for this. This is again you have already seen these uterine artery, and the ligation has to be performed. I will not go it, I'll leave it. Now this slide, I like it very much. Very simple slide, but I liked it. The line, there is a very thin line between hypovolemia and fluid overload. What is so good about it for the youngsters? That's very important to see. Both fluid overload and both hypovolemia, both will cause tissue hypoxia. So that's, you have to remember. If there is a tissue hypoxia, don't go and overload it, or don't be hypervolemic. Make a thin line and keep monitoring that, because the adequate cardiac output and organ transfusion is important for microcirculation preservation and good oxygen delivery. So that's, although this is this comes more in the field of the intensivist or the surgeon, the anesthetist standing on the head. But friends, then when a problem comes, it is the surgeon and surgeon only who is blamed for everything. So you have to keep an eye open for that also. Now, yes. So the pitfalls due to the anatomical changes during the pregnancy which occur. Uterus is big here. Operating space is restricted. Cervix is very soft. In fact, almost uterus and cervix becomes one canal. So difficult to identify where the cervix is. If it is effaced and dilated, then how to where it is starting. Blood vessels are also very greatly dilated. एक बड़ा बड़ा मोटा मोटा sinus दिखता है black में, more bleeding. Varices in the mesosalpinx and vesicouterine space, they all are the reason of massive hemorrhage. Because of the other associated conditions, what pitfalls can happen? There is an anatomical distortion also sometimes. One is the dextroversion. Then there are hematomas, they form, or the tumors, by any chance if there, then they will distort the anatomy. Vascularity, I've told you, very increased. There is a tissue friability. And if there is a placenta previa and accreta, you must have seen that as soon as you open the abdomen and see the uterus, on anterior cervix, big sinuses are running there, and you don't know where to put the incision, how to take out the baby. So adhesion of the bladder and lower segment may be there in cases of the previous LSCS, with more liability to urinary injuries. That's again a thing. So now let's see some steps. I'll show you a small video also for that, so you can understand better. I think most of you know it, but still. Skin incision, both midline or low transfers can be given. Midline incision is preferred because here you might need to be, more exposure is required. So depending on the surgeon choice we can give. If transverse incision is made, then it has to be extended. Maillard incision becomes better for good exposure. And avoid the incision as well as removal of the placenta if there is a known previa or accreta. So always go for an ultrasound before, and if unless and until the patient has come in emergency and then you don't know anything. So consider in these cases classical uterotomy, upper segment incision and taking out the body, close it, delivery, and then the adult placenta left into the C2 and go for EPH. Careful bladder dissection of anterior lower uterine segment, if possible. If not adhere, sharp dissection should be preferred compared to minimize the bladder injury instead of pushing and blunt injury. And the bleeding aim is to 1 to 2 centimeter below the cervico-vaginal junction. Again, I would say, if possible, understand the ureteric anatomy. That's the one thing, so that you don't ligate and later on end up into trouble. Round ligament identification is very important. Double clamp laterally, as I was saying, they become very helpful. Uterovarial ligament, special care is needed because here the tissues easily tear. And the most important thing, because patient is very, very young and we have to save the ovaries. So no tear and no extension should be done towards the ovary. Otherwise, if we ligate or cauterize it, ovarian tissue will be damaged or sacrificed. Now identify the uterine vessels and apply 3 clamps can be used for extra security, 2 on the active vessel side and 1 on the uterine side. Cardinal ligaments, clamp, cut and ligate in 1 to 1.5 centimeter tissue section until we reach the external os. Now there you can see clamp across the vaginal angle, because that is the vaginal angle is again a very important thing. A uterosacral ligament enter the vaginal mucosa anteriorly. That is just like any total hysterectomy, just below the cervix, remove the uterus, secure the vaginal wall tangles and cardinal ligaments. Now, continuous or interrupted sutures for closure of the vaginal wall, whatever can be used. The only thing is hemostasis has to be obtained. All pelvis should be copiously irrigated, suction and drain has to be put. It is always good if you have the slightest these type of cases, high risk abdominal, putting an abdominal drain will not give you any discredit. But if there you have to open because of the bleeding second time, then definitely that is going to be, I mean, from the patient side, you know how they behave. So before closure, each pedicle must be doubly checked for hemostasis. That becomes a very important thing, because then you are very secure. So this is just to show you the round ligament part has been, uterus is externalized in these cases, and this is the round ligament has been secured. This is our hysterectomy incision. And this, there's a window is made in the broad ligament, fallopian tube and uterovarial ligament, then you can easily remove it. Then this is the, you can see the clamp has been applied, and with the help of scissor, you cut it, and then if patient is bleeding, just clamp, cut and drop. And then later on, you can do the further suturing can be done. This here you can see the uterine vessels very closely, the ascending branch which is running up, and the relationship with the, this is the cervix, this is the lower, this is the cervix, this is the uterus, and here the uterine vessel enter it. Now, this is the uterine clamp, which is applied the one on the side which will be sacrificed, and this is the 2 clamps on the side which is going to be saved, so that for extra security. Then clamps are placed slightly below the level of hysterectomy, just like, because you have to remove this, you are planning to remove the cervix completely, and the uterine cervix is amputated. Then, of course, over suturing is done by the running or the lock sutures, whatever you feel complication. Now, before I go for a video, I'll just complete with this theory part. The maternal morbidity ranges in these cases from 26.5 to 31.5%. And the reasons are there. The blood transfusion has to be done always. Most of the cases, it itself has its own risk, though it is a life-saving. Then, of course, reactionary or infection, like febrile episodes. Perinatal death can be there, unfortunate part. Patient has been in a prolonged labor or rupture or something, the loss of the child is there. Bladder injuries, for that you have to be very careful. Wound infection, DIC, ileus, vaginal cuff bleeding, and adenexectomy. So overall, the maternal mortality ranges from 0 to 12.5% with a mean of 4.8%. So that is the thing for which we have to work together to save the patient's life and decrease the morbidity. Here is the video. You can see this is a case of pass. So the baby is being taken out from the upper segment, and then the uterus is just with the big stitches, it is being closed, and then the clamp applied. The clamp is being applied on all 3 structures, fundal structures. This here you can see, identify it. Then the window is being made, and then clamp applied, cut. And then it can be, if you are not, it is not bleeding much, you can suture it, otherwise leave it. Now here you can see very clearly lower uterine segment. See, I've tried to focus it. This is the uterocervical junction, you can see, and this is the lower part of the uterus, which is not clearly separable, and the blood vessels are lots of blood vessels. That is the uterine scar, you can see. And so we find a place where the blood vessels are less, and then the peritoneum, uterocycle fold of peritoneum is being separated, and the technique is from the lateral side. That is the thing. Lateral window is created on both the side, and gradually from that side we apply the clamp and keep cutting it. That is the way. It's now the opposite side, and this keep on doing the suction so that you can see the whole mass of the cervix is on the up, and the clamp is being applied below that. You have to tighten it very gradually so that it doesn't tear off. Now this is the opposite side. Again, the lateral window is created, and this, after creating the lateral window, separating the bladder, the clamp is being applied. And in the middle, some fish fibers are there. They are being again cut, and gradually this cervix, the whole of the bulk of the uterus, total hysterectomy is being done, and it is being cut from the part where there is no vascularity or minimum vascularity is there. You can see the cervix is just now, the vagina is open now. And the posteriorly also it has been cut. The video is not that clear as the Dr. Mitra, that has been made into the elective conditions. Now this is the uterus. See, whole of the surface is adherent placenta is there. So that is the reason we had to go for hysterectomy into this case. So finally, the take-home messages are: it is a life-saving surgery, difficult and different. Tissue is soft, friable, vessels dilated and distorted. Always keep them into mind that planned is better than emergency, but nothing can be done. Total is better than subtotal. Clamping and controlling bleeding is priority. Post-operative care is equally important because she can suffer with the febrile illness, she can suffer with the severe anemia, that you all have to be taken care. Communication and multidisciplinary teamwork is the key. Again, you have to have everybody at your back to support it. Departmental stimulated drills for PPH management. Here, I mean, I don't know, categoric can be done or not, but at least these PPH drills are definitely the very key steps into managing the PPH bleeding, saving the patients. Massive transfusion protocol. And if placenta is adherent, never try to remove it. Never try to do that nochectomy, we call it. Understand the anatomy of the ureter, bladder, and pelvic vessels. Here I would say take a few seconds extra to identify it instead of tampering with it and losing it. So thank you very much. With this peripartum hysterectomy, I hope it's clear. So thank you.
Thank you very much for the beautiful talk.
Lovely, Dr. Kiran, बहुत सुंदर.
Thank you.
You are such a good teacher. मोनिका, हम तुम्हारे प्रोग्राम में पूरा ही बैठे रहे, हम पूरा ही बैठे रहेंगे.
Even I am since very beginning.
No,
बहुत अच्छा.
Today it was like attending a live operative workshop from both of you. It was such a magnificent session that it felt like we are in, in a workshop. Sitting in the comfort of our home, we could see the cases, see the passion with which you operate, the passion with which you teach, and this makes you the best of teachers. We are blessed to
Thank you
have
so
both of
much.
you,
Thank
Kiran
you.
ma'am and Mitra ma'am.
Thank you. Thank
And
you.
Congratulations,
a word from
Mitra
Archana.
Madam, flawless Mitra Madam talking as if nothing was there. I mean, the passion is that we have to learn from her. So
Yes, so I
get
do agree. I do agree because Mitra Saxena,
Mitra ma'am, you got on mute by chance here. I think network. So, I mean, listening to Mitra ma'am and then Kiran Pandey madam, it is almost like, as you said, home theater and watching the best of the things with so many practical take homes, madam, as you said, close the incision. Yes, Vinita ma'am, you can continue with your plan. Vinita ma'am, you were saying something.
yes, Kiranji, she was marvelous. Both the talk was so informative, so wonderful talk, Kiranji. And Mitra Saxena, it was really wonderful. बहुत ही अच्छा लगा. And always, I love hearing you, both of you.
Thank you. Thank you so much.
Thank you.
I was saying that Kiran madam, the points, practical points you put up, like closing the uterine incision, not touching the placenta, having a tertiary care backup, blood products ready and properly counseled. And Mitra madam also, the power of documentation we cannot rule out anywhere. So thank you for making the thing so simple, and the depiction, the video and the diagrams which you used were also very, convincing for the people who are beginning. And we should not fear. We should always call for help. A senior obstetrician with you in such situations would make the sailing of the boat much easier. Thank you, Kiran ma'am. Thank you, Mitra. And dear
Thank you.
Monica, I
Thank you,
cannot thank you
Archana.
enough for making me a part of this beautiful webinar. Learning is an experience, it's a curve which is never ending. It's stalwarts here. It was a great pleasure for me.
And on for the record, the Symbiosis webinars are forever on YouTube. So anytime you want to watch Mitra ma'am's video again or Kiran ma'am's video again, you can simply just go on YouTube, log in and watch the video again. We'll be providing you the link within 48 hours. And moving forward, we have now the culmination of all the lectures taken. And these deliberations now will be, asked as questions by our able panel moderators. Over to Neetu.
Thank you, ma'am. Now moving ahead for the panel discussion, which is on case-based management of postpartum hemorrhage. And it is a very important topic. For moderating the panels, we have he is presently the president of Nagpur OBGYN Society, and he has been introduced. We were interesting panel. Our
Neetu, you can switch off your video. Your connection is not stable.
Moderator for the panel is
Neetu, you can switch your video. Switch off your video. Dr. Neetu. Dr. Nandini, are you there?
Now Dr. Megha, she has joined actually.
Okay.
Can we have CV of Dr.
Yeah.
Yeah, good evening.
Megha,
Good evening, ma'am.
Introduce only those panelists who are present, Neetu. I think Neetu is having some bad connection there. Dr. Manisha, are you there? Dr. Nandini, are you there?
Yes, ma'am. Yes, ma'am. I'm there, ma'am.
Dr.
I'm there.
Megha,
Good evening, ma'am.
Nandini, you please introduce the panelists.
Yes, ma'am.
Introduce
good
only those
evening.
panelists who are present.
Yes, ma'am. Yes, ma'am.
Yeah,
A very
just
good
check
evening
it.
to one and all.
Yeah.
I'd like to introduce our first panelist for the evening, Dr. Megha Kane. Madam is Secretary of Devli Sarangi of Skyning Society. She is presently the Assistant Professor in Jawaharlal Nehru Medical College, Wardha. Jawaharlal Nehru Medical College, Wardha. She has been a Secretary for Devli Sarangi of Skyning Society, and she is a Clinical Associate of Apollo Hospital, Classic Hill, Navi Mumbai. She has been a senior registrar in KB Bhava Hospital, Mumbai, registrar in Dr. R. Cooper Hospital, Juhu, senior resident in Nair Hospital, Mumbai, and she has also done her fellow in gynecological endoscopy from VNMC, DMI, HER. We welcome you, ma'am, for the panel discussion today.
Thank you for the introduction. Good evening, all seniors.
जेरे खालिक नाच जो भी पैदा लेगा सब चला जाएगा 27 साल
Our panelists, because we have the change in the panelist today. Our next panelist is Dr. Archana Dwivedi, ma'am. She is Dr. Archana, ma'am, President Vadodari, ma'am, for the panel discussion.
I'm there, my OPD, I'll be coming in and going, but I promised Monica.
Yes, ma'am. Yes, ma'am. Sure, ma'am.
The pleasure to be with
Yes,
Sandeep.
ma'am.
Thank you. Thank you so much. Thank you, Archana.
I'm there listening and responding when required.
Yeah, sure.
And next panelist will be Dr. Manisha Jain, ma'am, Treasurer, OBGYN Society, and my co-moderator. Jain, ma'am, we welcome you for the panel discussion. Next panelist is Dr. Nandini Singh Bhati. She is my co-moderator along with me for this program. And she is Assistant Professor, Gandhi Medical College, Bhopal. I welcome you, Dr. Nandini, for the panel discussion. And as a panelist, I myself will be there as one of the panelists. And over to the one more panelist we have with us. More than panelist, she will be a expert in this subject. Dr. Shabana Sultan, ma'am. She has worked in PPH bundle project and along with the Harvard University. I welcome you, ma'am, for the panel discussion as an expert.
Thank you, Nitu.
Now over to our moderators to carry forward the session.
So shall I start my screen sharing?
Yes, please. Yes, Sandeep.
So at the outset, I would like to thank the Fox's Practical Obstetric Committee, Medical Education Committee, Bhopal Obstetric Gynec Society, the host society, and all the delegates for giving us this opportunity to present this case-based management of PPH for panel discussion. It is horrifying for any father to see his wife dying and being left with a baby to look after it. A famous actor, Rajpal Yadav, had undergone the same trauma when his first wife died of PPH few years back. And these are his words when he first met his wife dying on a hospital bed, and he was carrying his baby in his arms. It's a very horrifying situation for a father. So behind his comedy lies the harsh reality of life. I would like to thank Mitra Saxena madam and Kiran Pandey madam for easing our management part, because they have covered the basics of internal iliac ligation and peripartum hysterectomy. You all are aware that the maternal mortality, the main cause is hemorrhage. That is, it causes the 31% incidence throughout world. And in India, National Health Mission conducted a survey, and they found that the PPH is the most common cause of death of women in childbirth in India, with 38% maternal deaths caused by it. So to discuss the management, we have eminent panelists, although because of technical difficulties, a few of the panelists have changed, and we would like to welcome all the panelists who are present here. Dr. Pragati, Dr. Megha,
Dr. Shabana, Dr. Nitu, Dr. Archana, Dr. Manisha, and Dr. Nandini. We welcome you all for this panel discussion. Coming on to the first case, this is a 38-year-old gravida 3 para 2 living 2. She was admitted in active labor at 38 weeks, 38 weeks spontaneous vaginal delivery 1 hour ago. She delivered 3.8 kg baby and she had a first degree laceration which does not require any repair. The placenta was inspected at the time of delivery and was found intact. She had just called out because she feels dizzy and more bleeding per vaginum. There was no history of any diabetic mellitus or hypertension. On examination, her pulse was 100 per minute, blood pressure was 100/70, and estimated blood loss was around 900 ml. So, the first question to all the panelists is, whoever can answer, what is your clinical diagnosis? Anyone can answer.
Traumatic postpartum hemorrhage.
Yes, madam. Right. Anyone adds to it? How you diagnose this?
Bleeding from a retracted uterus. When the patient is bleeding after delivery or even after a difficult cesarean section from a retracted uterus, because in cesarean you can see easily where the trauma is, but in cases of vaginal delivery you have to see that whether there is a cervical tear or vaginal tear. So the foremost important thing is the bleeding from a retracted uterus is the one diagnosis of traumatic postpartum hemorrhage.
But madam, in this case, this is a
We
vaginal delivery.
have to add.
This is a vaginal delivered patient, and there was a small cervical tear which doesn't require any repair. So it's not a traumatic delivery, this traumatic reason.
Okay, then just show me the slide again.
Okay. She had a vaginal delivery and she had a first degree laceration only, and which doesn't require repair also. The placenta was intact.
It may be a tonic PPH, sir, because
Yes, perfect,
nowhere it is
perfect,
mentioned the uterus is retracted.
Now
I
I
think
fully
prone
agree
for
with the slide. It is a case of atonic postpartum hemorrhage because the tear is so small, first degree, but she is bleeding.
And the big size of baby
But
is
we
not
have to take it into account this laceration also, because sometimes the patient may bleed from a small laceration.
I think, sir, with the point here highlighted is very well that she's a multi-para with big
Multi-para,
baby,
yeah.
and
She's a multi-para.
bleeding amounting to shock. Maybe we'll have to look forward to like proper PS examination. Also, if I mean, atonic PPH is one thing, but the sonography to look at lower segment, something is affected or not there, tear or something. So atonic PPH is something which is, I mean, universally accepted by all of us.
Yes, perfect. So we are dealing with the atonic PPH patient, right? So will you define PPH, Dr. Nitu?
Sir, PPH, many definitions are there. And one definition where this fits in is amount of blood loss in vaginal delivery when it exceeds 500, in cesarean when it exceeds 1000, and in hysterectomy, during hysterectomy when it exceeds 1500, it is PPH. And along with it, there is a clinical diagnosis for this PPH when there any amount of blood loss when associated with deterioration of the condition of the patient.
So actually we have two definitions, that is quantitative as well as qualitative. We are quantifying, I think qualitative definition is much more important, that any amount of blood loss which deteriorates her clinically, or for an anemic patient, it may be a blood loss of only 300 ml. We deteriorate her condition. Is PPH for her.
I think Shabana ma'am has made a very valid point. Patient who is already low in BMI and anemic already prior to the delivery, for her the indexes will be different.
Right. So what is the possible etiology in this scenario? Megha, Dr. Megha?
So then the cause of PPH here could be atonic PPH. So she has multiple factors, that she is a multiparous and she has a big baby. So atonic PPH could be one of the causes of PPH here. Secondly, we've examined the placenta, so it appears to be complete, but there could be a subcensurate lobe that could be still there in the uterine cavity, which is again contributing to the atonic PPH. Now, trauma we have ruled out by doing the examination. It's a first degree tear, but as ma'am said that a lower segment ultrasound should be done to rule out any lower segment damage, trauma, or even a broad ligament hematoma which is developing. And yes, so coagulopathy, we still have to see the blood reports as they come. So the
So
four
there are
T's.
4 T's for this. It is tissue, trauma, and
Thrombosis.
tone.
Thrombin and tone.
These are the different causes for this retained products of conception, that is retained cotyledon or subcensurate lobe or retained blood clots. And trauma to the genital tract injuries like laceration of the cervix, vagina or perineum, vaginal or paravaginal hematoma, extension of the lacerations at cesarean section, uterine rupture and uterine inversion. And coming on to the abnormalities of the coagulation, that is if there is patient is having pre-existing bleeding disorders, and some disorders like acquired in pregnancy like gestational thrombocytopenia or health syndrome, and the patient is having went into the DSC because of some other reasons.
I want to add something, sir. When we deal with a patient with postpartum hemorrhage, we usually start the treatment of the most common cause, that is the atonic PPH. Simultaneously, we search for the other causes also. When we start treatment and we search for the other causes like trauma and retained tissues, or the last, which is least but uncommon, that is coagulation disorders.
Thrombin disorders.
So we follow that we treat and as well as seek the causes what can be the other cause and rule out other causes also simultaneously.
Right. So how will you assess the patient? Dr. Archana?
This patient has come already in a partial shock condition, as you said. So we have to observe the bleeding, as Dr. Neetu said, pulse, BP. ABC is the monitoring which is has to be maintained, and we have to start the IV fluids to her and see simultaneously. One person has to look the PPH cause, which has to be identified per vaginal, and the team has to be identified previously, who will take care of the starting the IV line and calling for help, monitoring system, preferably. If we, and also if we into a small peripheral setup, we have to also make sound efforts for the referrals in the meantime. Sometimes if you have a NASD or garment with you, that can also help with this patient. While assessing, we can also instruct one person to get ready to apply that NASD garment also to that patient. And there is one more important thing, that we have to look for the bleeding, because sometimes what happened, patient is already covered and she may be into the pool of blood while being admitted in the hospital also. So it is very important to see the amount of soakage of the gauze pieces, the pad, and even the bed sheet, if the patient is in immediate post-operative ward. As you very well showed in the PPT over here, that the amount of blood loss is very important to be quantified to manage the patient aggressively, simultaneously finding out the cause.
I want to add on few things in the clinic. I want to add on few things.
Yes, Shabana madam. Yes.
May I? At the clinical judgment, sometimes it is very important to do it quickly.
Yes.
Because we have only 1 hour, golden hour, to manage the patient. And the fast clinical judgment we can do, not by measuring the things, but by the clinical condition of the patient. And we have to take into account the shock index, maternal shock index as well in assessing the patient. Yes, obviously this amount of blood loss, a rough arbitrary assessment can tell you that 30-40% कितना blood loss हो गया है, उसके vital से पता चल जाता है. But a shock index is also a good thing which we can add on. And a rule of 30 we can add on roughly. If 30% loss hai, so there is a 30% increase in the pulse. There is a fall in the 30 beats per minute, and like this. A fall of blood pressure index. So this is the assessment which we can do quickly, and then the cause, you are rightly said that the cause judgment is again important. So we have to divide a team into a leader, a communicator, an examiner, all these things.
So I think Shabana madam has put a very valid point, but we have to assign, like, mock drills are essential.
Yes, clearly.
We have
There
to be
should be
very
no-
clear. If A is called, it is supposed to do that, because everybody rushing for the same thing is not a option with the, when we are dealing with the patient of shock. So there should be A, B, C, D category in our staff, which must be regularly trained. Shock index is a very good parameter which we do follow. But we have to act simultaneously at various levels: the blood pressure maintenance, the oxygen, the cause, the light, the OT, everything. So the team definition should be a priority in this case, along with
Yeah,
assessment.
teamwork with a good communication.
So it's a good clinical point to assign a person for that particular parameters to monitor. So which laboratory test do you order on the at the time of diagnosis? Anybody? Dr. Megha?
So we will start with sending a urgent hemogram and sending a cross match, as we will require blood and blood products. Along with that, sir, we would also be sending the coagulation profile. And if we are suspecting cases of HELP, or if she's already preeclamptic, then we could even go for sending the KFTs and LFTs. But more important is the CBC and coagulation profile. Bedside, we may do the bleeding time, clotting time, as well as a clot retraction time. But if we have a lab and if we can clinically assess, then we can start the treatment as early as possible.
In your clinical practice, do you routinely do this bedside test?
Sir, since we are in a medical college and sometimes the labs, they take a long time to process, especially PTINR, then we sometimes do a bleeding time, clotting time. But in most of the cases, we rely on the lab to get the reports. And if it is required, so then only if the lab isn't working, then we go for bleeding time, clotting time, but not very routine.
Yeah, because there's no point in doing bedside test and spending your time, wasting your time in doing this bedside test, rather than focusing on the management part.
Yes, yes, sir.
So how will you monitor? So you already covered this. We'll skip this. So the management part now. How will you manage this? This is a case of minor PPH. Okay. So how will you manage this part? Dr. Bhagat is there? Dr. Nandini?
Yes, sir. I'm there. We will start with her monitoring her clinical signs, that her pulse, BP, her urine output. Will categorize the patient. Will monitor her RD urine output, and starting of management of PPH, we'll start with the giving her crystalloids. In case of major PPH, we'll give her crystalloids, at least 3.5 liters, till we arrange for blood. 2 liters of crystalloids are followed by 1.5 liters of colloids, and followed by giving her transfusing her blood. Meanwhile, we will start with the 14 gauge cannulas on both the hands, and we'll monitor her. And ABC are always assessed. They are being monitored. Then investigations are being sent, and meanwhile we'll look out for the patients.
Yes.
Shabana ma'am has correctly pointed out that all PPH cases should be managed in a group, in a bundle approach. That is, the first hour is the golden hour. It should not be missed, and it should be a team approach rather than an individual approach. And every team member should be assigned a task, and they have to do their task only, so that there is no chaos inside the labor room or inside the delivery room after the delivery. So the team which is managing the vitals, monitoring part, they will monitor the patient. The team which is managing, they will manage, and one team will be the connecting link between the two. What is happening, and pass the information from the monitoring team to managing team, and also to the outside to tell the relatives and go to the labs and run to the blood bank. That team should do, and it should be a team approach.
Yes, counseling
So
of the
these are
patient.
two more points I would like to add here, that make a very good friend, as Monica and Pragati were saying, that soulmates. So that call for help, she or he immediately reaches to you, because, and second point is that let the relatives see that you are working. Don't put up
Okay,
कि
yes,
आप
ma'am.
बाहर बैठिए और हम कर रहे हैं. That is very important to tell them that you are doing. They see it visually that the doctor herself is there, himself is there. That is very important. When we will, in spite of documentation also, sometimes they say कि I was not aware what was going inside the room. So these are the two things which I would like to add. Otherwise, covered nicely.
I would also like to add one thing in this. In our hospital, we have a PPH buzzer. In case we suffer from a PPH, the labor room team will buzz it, and then whosoever residents are there free, or the consultants they are free, they'll rush to the labor room, and they'll automatically form a team, and it gets in a very organized manner. So the patient is managed organized.
Okay.
So in that case, we can also have a mock drills for that, as Shavana madam suggested. We can have mock drills for that, and doing it regularly, it will monitor our work and monitor the way we manage patients.
So that PPH buzzer is for call for help. So the first management part is call for help, make your team. Bundle approach is something like that. It is incorporated in our all the treatment protocol. It is nothing but the guidelines which we are following for the WHO. From the WHO, that bundle is only the thing that we do the things together. Should be no confusion कि हमें drips कब लगानी है ये. So the first bundle and the second bundle is like that. Everybody is aware, I think, that we do the massaging, then crystalloid, then oxytocin, and tranexamic acid is there in the WHO as well as in the bundle approach. And the supportive things like arrangement of blood, C for the tears, emptying of bladder, these are all the supportive things in the first bundle. So this bundle approach, the funda behind this is only that we do the things appropriately, correctly, immediately, without wasting any time. This is the one thing in the bundle approach. And for the minor PPH, I think first bundle is sufficient. That is massaging, giving uterotonic, crystalloid, tranexamic acid is the one. We want to gain more time, then we can switch over to second bundle, that is uterine compression and aortic compression, and so on.
We will come later on that. So the 2 points are very well taken by the panelists. That initially we used to have a slogan for shout for the help. So rather than shouting for the help, we should ask for the help from the respective person who is well in surgical management, who is well in blood products management, and who is well in managing the patients. We can ask for the anesthetist also, so that he can call his friend to help in this situation. So all these points are very well taken. So now the actual management will start with the, how will you manage the actual PPH patient? Yes, Dr. Neetu.
The management part of the PPH starts with the emptying the bladder, because the most common cause is the filled bladder. We empty the bladder, we do uterine massage, we give uterotonics and see the effect, and simultaneously we decide ki after this first dose of oxytocin it is not working, then we decide ki we go for methergine or we go for carboprost or misoprostol we give. And then when we see that it is not working, because everything is going hand in hand, we then switch on to the next approach. In simultaneously we give 1 gram tranexamic acid also. And when we see that it is not working after first dose, second dose of carboprost, third dose of carboprost, then we switch over to the tamponade methods. And when it is just stepwise, it will go stepwise management. And
so how much time you will spend on this assessing this and managing this medical management of this PPH?
Maybe maximum 2-3 minutes, 3-4 minutes, because we give this carboprost every 2 to 3 minutes, we give. And for the second dose and third dose maximum, when it is not working, then we should have a suspicion in mind that this medical method will not work. We go for the tamponade methods.
You have to assess the patient clinically and manage accordingly. So you have to arrange, make the necessary arrangement in next 3 to 4 minutes, and you should be able to decide whether the patient is requiring any further surgical management within 10 minutes of the delivery or when 10 minutes of the PPH augmentation. So what are the drugs available for medical management? The first drug is the oxytocin. Which is your drug of choice?
Yes, sir. Because it is used in active management of third stage of labor, but dose is 10 unit, which is given IM. Then we can give 5 units IV bolus, or we can give 10 units more IM, or we should put in the saline, which is hanging there, 20 units in 500 ml, and we let it run. But it is usually given in active management of third stage labor, so we should switch over to other drugs like misoprostol and methergine and carboprost, depending upon the indications and contraindications, because we have to keep in mind the contraindications for these drugs also.
But the first preferred drug for management also is oxytocin. You can give in diluted form, it's oxytocin. IV bolus, I don't prefer.
Right.
I prefer giving it in diluted form. This is the preferred uprotonic. Methyl alcohol, we can go, it's a quick action, but the contraindication are so many.
So how will you give the IV bolus, the IV preparation of oxytocin?
IV oxytocin, sir. IV oxytocin is 5 units. 5 units is maximum, and it is given slow IV. If it is direct IV.
Diluted
diluted it is 20 international unit, 20 international unit in 500 ml of Ringer's lactate. We can give 20 international unit.
So better the first dose you should give the 10 international unit and followed by the 20 international unit.
20 in IV fluid. Yes, sir.
Yeah. So another drug is ergometrin, methyl ergometrin. We have covered this.
Yes,
Misoprostol we have already covered.
Ergometrin, it is.
Anything specific about the ergometrin?
Ergometrin, sir, it should not be used in heart disease, severe anemia, and hypertensive patients. And it can both be given IV and IM. IV with very much of caution, because it can cause sudden vasoconstriction and other cardiac effects. And it is given because the next dose will be given after 2 to 4 hours. So after single dose, if it is not working, then we have.
So coming on to what is the maximum dose we can use for all these drugs like oxytocin? Dr. Mitra is not there. Dr. Megha. Yeah, madam. Madam, Dr.
I have stopped using methergine. I use carbetocin.
Okay.
So
carbetocin is prophylaxis, na, ma'am. It is not given for management of PPH.
See, if what I'll tell you, this shelf life is 60 minutes. Once the baby is delivered, anterior shoulder is out, you give carbetocin. It is going to seal the blood vessels more effective than methergine. Yes, oxytocin cannot be replaced by anything, but I have stopped using methergine in my practice. I don't know about others. I would like to share what listen to.
We are also using methergine in our medical college. जब हम स्टूडेंट होते थे मिथार्जिन काफी यूज होता था, बट अभी ऑक्सीटोसिन मिसोप्रेस्टोल रिप्लेस हो गया है. बट कार्बेटोसिन पे वी आर डूइंग प्रोजेक्ट. इट इज ओनली फॉर द प्रोफाइलेक्सिस, नॉट फॉर द मैन.
Because this is the highest case.
It's a very good.
मैडम, यस
मित्रा मैम, हाँ मित्रा सक्सेना मैम.
हाँ, मैं भी सुन रही हूँ. बिल्कुल बहुत बढ़िया चल रहा है. Excellent questions and excellent answers. I just say कि although we know carbetocin is only for prophylaxis AMTSL, okay, electively. So what I have started doing in my practice कि जैसे जो भी inductions हैं, जो big babies हैं, जो ट्विन मतलब wherever I am expecting कि there will be atony, वहां पर मैं ऑक्सीटोसिन की जगह कार्बेटोसिन दे देती हूँ. एंड आई टेल माय स्टाफ कि अब इसका सिंटो ड्रिप हटा दो, बिकॉज यू नो दे आर द सेम रिसेप्टर्स. तो अब आपका कार्बेटोसिन इफेक्टिव आ गया है, तो वी आर प्रिपेयर्ड. आई हैव टॉट देम कि अगर कार्बेटोसिन फेल होगा तो फिर वी हैव टू गो फॉर मेथर्जिन एंड यू नो कार्बोप्रोस्ट एंड ऑल. द ऑक्सीटोसिन विल नॉट वर्क. बट थैंक गॉड टच वुड जिन जिन में कार्बिटोसिन यूज करते हैं तो एटोनी होती ही नहीं है. तो अर्चना इज वेरी राइट एंड थैंक यू सो मच. सॉरी आई वॉन्ट.
राइट मैम, दिस इज माय एक्सपीरियंस आल्सो, जिसमें भी
please.
कार्बिटोसिन प्रोफाइलेक्टिक भी यूज करा, लाइक इन सस्पेक्टेड केसेस ऑफ पीपीएच एटोनिक, एंड we got very good response and very good hemostasis. Even afterwards, post cesarean, post delivery, bleeding बहुत कम हुई.
I think I have got
Yeah.
enough support from
Yes,
stalwarts.
we also have been using carbetocin.
Justified on that.
Yes,
But
Yes,
madam, but
ma'am,
then
it's a very good
that
drug.
this,
In our project also, we
yes,
concluded like this, that it's a very good drug for the prophylaxis, and that's why it's a working time is more, and this thing heat stable is there. उन cases में नहीं होता है, but एक दो cases ऐसे सामने आए जिनमें if at all PPH is there, it is intractable, receptors they are already blocked, we have to go for balloon tamponading in those patients. Only 2 patients we find like this.
So I think madam has made a very valid point.
Yeah.
Sterile is the word. If you have to store oxytocin, please store in 2 to 8 degrees centigrade. क्योंकि staff की आदत क्या होती है, ये रहा oxytocin और लेकर के आ जाते हैं labor room से. So cold chain maintenance is important there also. And for carbetocin, in Gujarat, madam, we are reaching 49-50. So I think we'll have to store it in fridge sooner. And otherwise, it is more heat stable. That is already been said.
madam, this carbetocin, according to WHO and the FIGO and even our FOXY, they have recommended its use as a second line drug for the management of prevention of PPH and not for the management of PPH. Right now, our patient is in mild PPH, so we will go with the oxytocin.
Sir, but our patient has got all valid indications to use that multipara with big baby. So
yeah, no, but then this is the evidence based, madam. Okay. Rather than giving this carbetocin, you can go for the tranexamic acid.
Great.
So,
We accept everything.
yes, Dr. Shabana, madam, how will you give this tranexamic acid?
Yeah.
Perfect.
Because if we're following the guidelines, we can only use carbetocin in the prophylaxis. For the management part, our choice is oxytocin, misoprostol, tranexamic acid.
Right. So now that FIGO is now with the LDA project is going on, and there they are giving this tranexamic acid is in a 1 gram dose. How will you give this tranexamic acid, Shabana madam?
Yeah, we are using it 1 gram.
Yeah, diluted 1 gram.
Diluted 1 gram we are using, and we can just repeat it after 10 minutes.
After?
After 30 minutes, we will repeat.
Yes. So, and if after 2 hours also the patient is bleeding, then you will repeat that dose?
No. If the bleeding is controlled, we are not going to repeat.
Okay. So it is better not to give the third dose. We can give the third dose after the 24 hours of the first dose. Okay. So another this update on the tranexamic acid is you should not lose your timing of the management. And for every 15 minutes, there is a 10% decrease in the survival benefit. So it is better to give the tranexamic acid as soon as possible if you think that patient is going for a PPH. And after 3 hours, if your patient is still bleeding, there is no point in giving the tranexamic acid as an injectable. So this is an update on the 2017 update on the tranexamic acid, that you should give the initial dose at the whenever if you suspect the PPH, and then repeat after the 3 hours, and then you should not give the prophylactic next dose after the 24 hours. So this is a chart showing different pharmacokinetics of all the drugs. So my question to panelists is, which uterotonic you prefer? I want to answer from all the panelists. We start from the Dr. Neetu Mishra.
Sir, I first prefer
Only one.
Only one.
Yes.
Then I have only one in hand. I will use some misoprostol.
Okay, Dr. Megha.
Given the choice of one drug, then sir, misoprostol, because least side effects and contraindications. So misoprostol, one drug.
Dr. Nandini.
I will also go for misoprostol because it is easily available in peripheries also. and does not require much things to store and can be used by any ANMs also. It doesn't require a lot of knowledge for its use.
Okay, Dr. Manisha?
Sir, I would prefer methargin because this is the only drug which causes also lower uterine segment contraction. So still for
Yes.
me, if only one drug, I think methargin is the best uterotonic.
Okay, Dr. Nandini?
I already gave my answer, sir.
Sir,
Okay, already done.
after listening to Archana ma'am, Mitra Saxena ma'am, and one more, I may go for carbitocin. Next time ki hoga hi nahi PPH when I give carbitocin. So I may not require any
Into
drug.
medicine, huh?
So the problem with the
Boss,
misoprostol is
don't
that
underestimate the power of uterus. It can become flabby with best of things.
Problem with
God has to be on your side.
Yes, right, ma'am.
no, but the problem with the misoprostol is that it
oxytocin,
starts
sir,
working after 8 to 10 minutes. And if the,
Actually, if I'm allowed to say my one observation,
yes,
I was looking at the master chart of all the recommendations, FIGO, WHO, FOXY, ACOG, etc. Out of all of the recommendations, I found the Canadian recommendations and the Australians more intelligent. They're actually using carbetocin as a uterotonic. Rest, all of us are still towing the line that it is a prophylactic thing. Fact of the matter is that many of us are having the experience कि भाई बहुत बढ़िया contract करता है. तो अभी चक्कर क्या है कि we are waiting for the recommendations to change, but I'm quite sure that there'll be more takers of carbetocin as second line agent also. Let's see. I don't want to say anything which is off the track, but SOGC and that means the Canadian guidelines and the Australian guidelines, they are using carbetocin as a
they are using,
uterotonic.
but the Canadian task force also recommended the oxytocin as the first line of drug treatment because it has an immediate action. If you go through this slide, it has an immediate action. Carbetocin requires 2 minutes for the action, and misoprostol requires 9 to 15 minutes for its action.
Yeah.
So coming on to this question, and answer is like this. The first line is oxytocin, second line is carbetocin or misoprostol, and third line is carboprostomethadone. Okay.
Can I ask one question? Excuse me.
Yes, ma'am.
Yeah. So if we at all want to give bisoprostol, so which route is preferred? Is it the oral or the vaginal route?
Rectal, ma'am. Per rectal, we should.
Yeah. So
For
what
management, we are giving rectal.
Yeah.
And for the prophylaxis in the periphery, we are supplying it for the sublingual 6 centimeter.
Right. So for prophylaxis is the oral route that is preferred, and if we are using it as a treatment modality for the management, then I think parectally. And what about the use of misoprostol as a prophylaxis before high-risk cesarean sections? How many of you are using misoprostol as a prophylaxis per rectally even before giving incision? Have you used this in particularly in high risk patients? For example, we have this HELP syndrome patients, or where we have this anticipated postpartum hemorrhage in the over-distended uterus twin pregnancies. So, is anybody giving routine placing misoprostol per rectally?
Not
before not for the prophylaxis per rectal. We are not using.
But then this is the usual scenario in a labor room. अरे कुछ थोड़ा सा ब्लीडिंग दिख रहा है क्या तो डाल दो पर रेक्टली मिसोप्रोस्टल.
ये तो कहते हैं.
Usual scenario.
बेबी आउट के बाद डाल देते हैं सर. बट बिफोर एनेस्थीसिया वी डोंट प्रेफर बिकॉज वी नेवर नो कि किस पेशेंट को फिर मतलब शिफ्ट करना पड़ जाए ना इमरजेंसी में. दैट्स व्हाई.
Yes, Rujita. Shall we go ahead?
Yes.
So if you are not a doctor and you are a community health worker and the patient is having in a PPH and you are working in a rural hospital, so which will be the drug of choice for you?
Misoprostol.
Misoprostol. Yes. Dr. Neetu?
Sir, misoprostol. It is obvious, sir, misoprostol.
We want Mitra Madam's opinion. Mitra Madam is there?
Yeah, you're right. In community health workers, and especially they don't have facilities for cold chain to be maintained. That is why tablet misoprostol is very safe. That's why that is recommended.
Right. So
Because carboprost also has this thing that you should take the history. She should not be having asthma. And methergine again has got a list of contraindications. Misoprostol per se doesn't have, and storage is very simple, so that's recommended for health workers.
Storage of
may I add
misoprostol is not a
something,
worry. Carbetocin should be
May I
the
add something?
So best is misoprostol, right?
So may I add something?
Yes, madam.
Even in community setting now, the Japango is promoting self-administration of carboprost by patients themselves.
I'm not getting you, madam.
For community settings, there's a program where there's self-administration of carboprost by patients themselves.
Misoprostol, Manisha, it's
misoprostol.
misoprostol.
Yeah, misoprostol.
It's
Yeah,
not
misoprostol.
carboprostol.
No,
Yes,
misoprostol.
they are giving to the community.
Yeah,
These
for
small
misoprostol.
skill bar
In
the training
community
and all.
setting, yeah.
Everybody. Misoprostol is a thing which is a choice for the community.
Yeah, no
also.
carboprost, misoprostol. Yeah.
Yeah.
Thank you, madam, for your input. Now our patient is assessing the patient, and after 10 minutes of this, her bleeding is not stopped because of all those medicines we use. This carbetocin and misoprostol and then oxytocin, everything we use. But still, after around 15-20 minutes of assessment, we had a pulse rate of 140 minutes, BP is going down to 80/60, and estimated blood loss is around 1700 ml. So what will be the next line of treatment?
Obviously, sir, we will go for the
Mechanical methods. We go for the manuals, compression manuals and mechanical method. Balloon tamponade.
So which compression manager you are using in your practice?
Both aortic and bimanual you are using.
Balloon.
Bimanual compressions.
Bimanual
Yeah.
compression.
And balloon tamponade.
Balloon tamponade.
Bimanual and balloon tamponade, sir.
So how will you perform this bimanual compression?
Anterior fornix
hand.
You have to make a fist, sir.
Yeah.
We have already taken all the antiseptic precautions, laid the patient in the lethargic position. Bladder should be emptied by putting in the catheter. Wear proper gloves of that fit in your size. With proper, I usually use xylocaine jelly while applying the pressure in the patient. Put your fist inside, and from the abdomens and the uterus, you can feel very well. So one hand in the vagina, which is in the fist form in the posterior fornix, and the other hand comes up, which is in a slight cup C shape. So the uterus is squeezed in between, and that is the time when you try to compress by slow, gentle movements. And this fist, this is the way we should ideally do the bimanual compression. And in the meantime, arrange for other measures what you had mentioned in the previous slide.
So for how long will you give this bimanual compression?
Sorry, sir.
For how long you will give bimanual compression?
How will I told you how will I do? I couldn't get the
No, how long?
How long? See, sir, that depends on the patient's uterine contraction. That is why I said I will not just keep on doing that. Then we have to be prepared with the other measures simultaneously. If it is not working for 5 to 10 minutes,
yes,
not more than that, we have to be prepared with the packing, whatever facility available in our setup, even Bhakri balloon, even Foley's tamponade, whatever, keep on instructing the staff so that things are lined up. Even aortic compression is a very good thing which can be done in this patient. You are in the next slide only. So that is again a very important part, the next step. So that can be given an NASD garment. I have two in hand, which is always ready. Though we all pray that that doesn't be never be used, but these are good things that can buy us time to refer to the patient to a tertiary care center.
This aortic compression was devised by US Army for the management of severe bleeding in soldiers, and now such instruments can be used for our management of the PPH also. And another is the hydrostatic balloon. Anybody using this Dr. Borke's ESM UBT kit?
Yes, sir.
Yes,
Yes, sir. We use it in project.
Okay.
We did project of bug balloon, ESM UBT,
Mm-hmm.
So
So
fortunately,
what is your
along with
experience?
Sevagram.
So what is your experience with this?
Sir, it's good for the moderate PPH, but not for the intractable PPH. Bakri balloon is much better than this bug balloon. It's good. It's good than normal Foley's catheter because the quality is quite good of this bug balloon. And one more thing is this thing for inflating two balloons are there, and slippage rate is less. But obviously, for the intractable and the massive postpartum hemorrhage, we find it sometimes it's not working. It's the Bakri balloon which is giving more pressure.
So I think whenever we talk
or
of
cost
PPH,
effective probably, so it's little cost effective if you compare with Bakri balloon, but that it can be used in our setup where, I mean, peripheral areas where you cannot invest too much. It comes as a rescue.
yeah, it is just costing 700
Yeah.
or something 800 rupees, and Bakri is costing around 6,000 rupees. But I think whenever we talk of PPH, we should talk of whether it is from the we talk of the traumatic PPH or the autonomic PPH. But we should talk also of the whether it is from the upper uterine segment and the lower uterine segment.
Exactly.
So for the lower uterine segment, will you prefer this type of UVTs?
Many a time when it's bleeding from only the bed of placenta, in cesarean section also, sometime focal accretas, we have used in lots of many patients of focal accreta. This balloon tamponading is quite good in those patients, bleeding from lower segment. We actually compared three balloons. One is Bob, another is Elavi, another is Bakri.
So here in Gujarat, we have Dr. Mahendra Soni who has got his own Pagadi pack. So
Yeah.
tight, good vaginal packing sometimes comes to us rescue if we don't have any balloon for our this thing. So that is a age-old, I mean, medical college therapy, which
Yes,
when we were student, we were only doing packing, tight uterine packing. Yes.
Yeah. In JJ, we were used to have this Shivkar's pack. Dr. Shivkar was there, and he used to taught us the Shivkar's pack.
I'm glad there are so many takers for packing because those of us
Mitra ma'am,
who
it
use
is the only
packing,
Sahara
they
for
are so comfortable. But you know what? Interestingly, people who are doing the balloon tamponade, they're equally comfortable with that. So maybe it's just transitioning from one to the other. But of course, balloon tamponade is accepted, and now we are hesitant to own up. But believe me, in atony, like sir, doctor was asking Archana ki kitni der tak bimanual. तो भैया जितनी देर तक तुम्हारा नेक्स्ट तरीका तैयार होना है उतनी देर तक दैट इज द थिंग
Yes, ma'am. Right.
and wait for your oxytocin to bring the effect so
So very
be
additional
prepared for
point.
the next step and see the effect
Right. ऐसा नहीं कि 10 minutes हो गए अभी छोड़ दो इसको अभी कुछ नहीं होने वाला इसका करके
हाँ
by
बिल्कुल
that time you
बहुत
should have next
your
arrangement.
panel is excellent बहुत मजा आ रहा है
एक्चुअली क्या है मैडम, अगर पेरिफेरल सेटअप में जाए जहाँ रूरल में जहाँ पे एक डॉक्टर एक नर्स है, आई थिंक द पैकिंग इज द बेस्ट रेस्क्यू पॉइंट देयर. Balloon, we need some amount of light, good facility. So I mean everything is usable wherever we have to make the patient right. At least to refer it to a proper place, everything comes to the rescue.
Ma'am, many a times when balloon fails, na, this packing works. I have seen. I have also seen this. When balloon fails, this packing is wonderful.
Press, pack, and pray.
Yes, pray is very important. Pray is very important.
So this is another this anti-shock garment. So if at all this tamponates failed, then what will be your next step?
Go for compression sutures.
So we have to go for the surgical management now. So we will go for the, if the patient is having atonic PPH, then we will go for the compression suture. So what is the best compression sutures you were following or you are using in your practice? Dr. Archana?
So we are using Comog MG and very comfortable, user friendly in our setup. I mean, there are so many other sutures. I would not go into the detail, but if you ask me practically what I'm doing this.
Which one, madam?
It's a Comog MG suture, sir. Comog suture is what we call. It's a vehicle with a 2 needle. I mean, we go across.
They were talking of suture material.
No, the technique.
Actually, Dr. Sandeep, this is devised by Dr. Mahesh Gupta, and this combines the uterine artery as well as the B lynch. So, you know, there are 2 needles. One needle you pass, जैसे आप यूट्राइन आर्टरी का करते हैं वैसे लीजिए, एंड देन एक नीडल थ्रेड से आप यूट्राइन आर्टरी को लाइगेट कर दीजिएगा, और दूसरा थ्रेड जो है वो एंटीरियर पोस्टीरियरली यूट्रस को कंप्रेस कर देगा. सो ऑन बोथ साइड्स यू हैव टू यूज दिस कोमॉग compression of uterine artery and compression sutures. They combined this, you know, things.
Heyman and uterine plus. Heyman plus uterine is Comog.
Not Heyman. Yeah, you're right, Dr.
Heyman
Neetu.
plus, yes, ma'am.
Heyman plus.
That's right. Heyman and this thing. But it's basically, sir, a transverse and a perpendicular. So
Yeah.
once the tie, it is taking care of the vessels.
Like this.
Yeah. This is Heyman and with uterine.
Towards the, I mean,
That is global type.
lower edge. So
Yeah.
lower segment is also taken care of and upper segment also. So this is a very good thing. It comes.
Not lower segment exactly. You are dealing with atonic PPH, and atony is from the upper segment. So stepwise devascularization is also a part of managing atonic PPH. So uterine, you know, when you ligate both the uterines, you are decreasing the blood flow to the uterus. So again, uterine artery ligation is for atonic PPH. And then B lynch is a compression suture. So in Comog, you are combining both together. Stepwise का पहला यानी यूट्राइन आर्टरी दोनों तरफ से और compression. That is Comog.
So which will you do first? Whether do you go for the uterine artery ligation, that is uterine artery ligation, or this Billings suturing?
So in this technique, it comes simultaneously, sir. Compression and occlusion both occur simultaneously. The Comog MG, what Mitra madam has explained very nicely. So if you have to take a B lynch, it has to be a separate. I mean, B lynch is a technique entirely different. I mean, here we are combining.
B lynch, Archana, B lynch is taken if you are doing cesarean section.
Yes.
Our patient is having atony, so there is no, it's a vaginal delivery if I am not mistaken.
Yes.
So here it will be, as Dr. Neetu said, it will be Heyman if you are using the compression. And then of course Comog means uterine artery भी ligate कर दिया horizontally और vertically आपने वो भी कर दिया compression भी. तो basically speaking मतलब इतना atony हो रहा है आपको compress करना पड़ रहा है. मतलब basically my learning is whatever you do, if it's a surgical thing also, you should monitor that the vitals are stable, bleeding has decreased, and you can close the abdomen. So that is the take point. खाली compression suture से भी आ गया तो भी ठीक है, uterine artery ligation से आ गया तो ठीक है. मतलब you cannot risk opening up the patient again. Whatever you do it.
Yeah. So the point taken is whether whenever you came across the PPH and you have to open the abdomen, then you go for the O'Leary stitch first.
Definitive, whatever is the best.
Yeah. And if the uterus is open, then go for the modified B lynch or B lynch technique. Or if it's not there, then go for the Heyman suture or MG suture. Right, madam?
Yes, sir.
Yeah. Very nice. Very good.
Yes.
सबके एड्रेनलिन सिक्रीट करा रखे संदीप, छोड़ के नहीं जा पा रहे हैं.
PPH manage कर रहे मैम.
Yes. So this now there is the Pereira breast suture is also there for this upper segment, and if it is not getting control, then you can go for the Pereira breast sutures also. And suppose if there is a placental side bleeding, then
Then we will take box suture, placental side sutures, we take box or figure of 8.
Right. So these are the core sutures we can take on the placental bed sides. We can take on the upper segment also and the lower segment also. And which suture material you will use for that?
Sir,
Neetu madam?
sir, I use Vicryl, sir.
Okay. Anybody using catgut for this?
Actually, chromic catgut number 2 should be used for compression sutures because that's the thickness of the suture you need. Vicryl is pretty, scary that way that it'll stay there. And the uterus is going to involute in no time, 24 to 48 hours. So basically, we all should have number 2 chromic catgut in our OTs
Yes,
for the
ma'am.
compression sutures. Ideally, that should be. But as Dr. Neetu has mentioned, we are nowadays, बड़े smartly Johnson and Johnson ने तो chromic catgut खत्म कर दिया है.
हटा दिया
It's the
है, ma'am.
other companies which are providing chromic catgut. So, sometimes we are handicapped because of the availability of sutures. So that is the technical point.
Yes, madam. But still, I am still using a chromic catgut for all these surgical techniques. And problem with the
हमारे
Vicryl is that
institute
if
में
you do the extra
availability,
force, no, it will break. It will injure the uterus also sometimes.
Availability is the issue, as Mitra ma'am
If you use the Vicryl on the uterus and you try to tie it on the knot, then sometimes it causes a cerebral damage also.
cut through हो जाता है,
Cut
sir.
through हो जाता है, cut through हो जाता है.
Many a times, yes, sir.
So which compression
Dr.
suture
Neetu,
will
sorry,
you-
one question. Can I ask you? आप किस institution में काम कर रहे हो? I missed that.
एम्स भोपाल में है, मैम. Because same Johnson and Johnson के आते हैं, they are not
मैं
providing
आपसे
catgut.
बात करूंगी अलग से.
Yes, ma'am. Sure, ma'am. Sure, ma'am.
So which compression suture you use?
I'll take number from Monica.
Yes, ma'am.
So if there is a compression on the, if you have to give the compression on the upper body of the uterus, then the B-Lynch, Heyman, and Pereira sutures are fundamentally devised. And co-suture can be used for bleeding from the sides other than the uterine body, and its compression is tight. So co-suture is better for the lower segment bleeding and placental side bleeding. So if at all the bleeding is not controlled, then we will go for the stepwise devascularization. So how will you go with the stepwise devascularization? Nandini madam?
Yes, sir. For high and low, it is basically low uterine artery ligation. Followed by, we'll go with ovarian artery ligation at the corner length, bilateral. And followed with, as we have been demonstrated very nicely today in the lectures, we'll go for internal iliac ligation.
Yes. So here you can see the O'Leary stitch is being taken. So which suture material you are using for this O'Leary stitch? Mitra madam?
Yeah, we using.
Come again, question क्या पूछा?
Which suture material you are using for this O'Leary stitch?
Uterine artery, Vicryl only. Take Vicryl only. ये डॉक्टर सुमिता मेहता का वीडियो है.
Yes, madam.
It's a beautiful demonstration. ये आपका है. Yeah.
This is the ovarian artery ligation. You have to take care of the fallopian tube. You have to go into the mesosalpinx. And the uterine musculature. So we have already covered this intra-aortic ligation and peripartum hysterectomy. So we'll skip this. So how will you monitor the patient? Hello.
Sir, I have one question, sir.
Yes, madam.
मुझे ना मतलब because this is my genuine doubt from my PG days which is not been cleared yet. जब हम ये सर ovarian vessels बांधते हैं तो what happens to the tube? Because
You have to leave the tube, fallopian tube. You don't have to take that tube, fallopian tube in the future. So nothing will happen as a
because after uterine na stepwise devascularization में I go for internal ileal artery rather than वो tube ovarian वाला because many a times it is difficult कि मतलब
No, you are very right, Neetu. I think I'll be standing by your side. But actually, sir is also right because collaterals are there. They do take care of. But yes, I'm also very skeptical about going to ovarian directly.
But it is better to
making
go
it
for
so
internal.
easy for internal lilac. I think it is more.
So, I just wanted to add. Hello?
Yeah,
Yes,
Pragati,
ma'am.
please.
I'm not seen. I'm not able to see myself.
Yes, ma'am.
Okay,
You are
anyway.
visible.
I can see you. All of us.
I'm not able to see
We
myself.
can
तो
see
मुझे
you.
कटा
We
कटा
can
लग रहा
see
है
you,
सबसे.
Pragati.
What I'm saying, see, we have to ligate uterine branch of ovarian artery. Uterine branch of ovarian artery. So it will not hamper any flow to uterine artery. To ovary. So that is it, and that is the nick of tying ovarian artery ligation. What does Sandeep says, Dr. Sandeep?
Yes, madam.
Isn't it? It is the uterine branch of ovarian artery. Just to ligate it.
Actually, you know what? The beauty is this, that although uterus receives 90% of blood supply from the uterine artery, but you know the anastomosis with the ovarian artery does with the uterine, as Pragati has rightly mentioned, they are, you know, those vessels are lying collapsed. तो अगर आपने उन्हें ligate नहीं किया, and actually you're not ligating ovarian artery, you're ligating that branch of ovarian which is anastomosing with uterine, आप उसको ligate कर रहे हो. तो ओवेरियन आर्टरी को आप नहीं कर रहे हो, आप यूट्राइन ब्रांच, क्योंकि आप कॉर्नू के नीचे कर रहे हो, तो आप उन पोटेंशियल चैनल्स को जो ओवेरियन से भरेंगी, आप उनको बंद कर रहे हो, आप ओवेरियन की रूट को नहीं कर रहे हो. सो द सप्लाई टू ओवरी विल स्टे, बट द अगर आपने नहीं किया तो ये जो चैनल है एनास्टोमोटिक, ये अगेन कॉज करेगा ब्लीडिंग फ्रॉम द यूट्रस. सो आपको यूट्रस की ब्लड सप्लाई बंद करनी है, ओवरी की नहीं. प्रगति, यू मेंशन वेरी करेक्टली.
Thank you,
Even if you are not ligating the IP ligament, so ovarian blood supply will not be compromised.
Correct.
Yes, sir. Yes, ma'am. Yes, sir.
And one more thing, when you're doing this ligation, you have to take some chunk of myometrium to have a good ligature.
Right.
Otherwise, it cuts through. Now, so you have to take some chunk of uterine myometrium and then take the vessel and then ligate it.
Like what we do during the uterine artery ligation.
Yes. Yes, please continue.
These are the different charts of monitoring. We will not go in detail of this.
Yeah.
Now coming on to the second case. Now Sita got stabilized, and because of all your efforts, now this Gita came. She came in a labor room with 26-year-old primary gravida with uneventful antenatal course, delivered at term with an episiotomy, resulting in the birth of a 3 kg child with normal Apgar score. She has no risk factor for PPH. After delivery of placenta, brisk hemorrhage is noted even after 2 doses of oxytocin. Placenta is complete and the uterus is firmly contracted, and there are clots in the vagina. So, what is your diagnosis and how will you manage it?
Needs to be seen, sir. Exploration.
It is obviously traumatic PPH, sir. Retracted uterus.
Like I'm already told, bleeding from a retracted uterus is always traumatic.
So we are dealing with the cervical tear. So how will you prepare this patient for a surgical repair? What are the different suture material? Which suture material you will use, and how will you repair?
So good exposure, good light and good exposure is key. Proper positioning, drain out the bladder, and then hold the cervix with sponge holding forceps and identify the apex. That is the most important point. Apex should be identified. And if it is not identifiable, we take the suture and then pull the sutures to get the sutures beyond that apex.
Right.
Then we stitch it. And again, suture material to हमारे लिए Vicryl ही है sir.
That's good.
This is rapid Vicryl.
Vicryl rapid or
So now you sutured this and the patient
So
got
can
stabilized.
I add my little 2 pence? Right, can I add my case here? Just 2 days ago, me ROT, and she was her vagina was very muscular, so I had to give her a episiotomy, and then the last bit I had to do a single pull of the vacuum. And here I had used carbetocin, so uterus was well retracted, but I was anticipating that there will be some tear or extension. And because she was very exhausted, and when I palpated, my first thing is that even before I put in the speculum, I do a thorough, gently, digital examination of the vagina with lubricated fingers. And believe me, you can easily make out, your fingers are so deft at recognizing disruption in the vaginal walls. So I could actually feel the, vaginal tear extending right up. So what I did was I just packed her and I called my anesthetist. So in primaries, my thing is good light, good anesthesia, good exposure, and do it right the first time. So that is the thing I feel every one of us should do. So in this patient, I was able to stitch everything very nicely because I packed her, and her vitals remained stable. I was fortunate that the tear did not, it just lacerated the vaginal mucosa. No major vaginal artery or something was ruptured. So good for me. But anyhow, I had to get a cervical tear as well. So anesthesia is really, really important, and good light, good assistance. And like Dr. Neetu said, go above the apex.
So my question is, Dr. Shabana, if she's there?
Yes, I'm here.
Okay.
Yeah.
So if at all you could not find the lacerated cervix apex, so what will be your next step?
Well, we have to see, Doctor, that whether it's extending up to the lower segment or not, or the lateral fornix. That is a one very important thing. And by palpating that it's going right up to the lateral fornix and making a broad ligament hematoma also, because working in a tertiary care center, we sometimes find these type of cases, patient coming delivered somewhere, coming with a huge this thing tear of cervix, standing right up to the lateral fornix and then there is a broad ligament hematoma. So if we are not getting apex and hematoma is not palpable, we can repair it if the patient is going, depending upon the clinical condition. If she is going in shock and a bulge is there in the broad ligament, I think we have to open it and properly manage.
So then how will you feel the bulge of the broad ligament in the enlarged uterus?
Sometimes there's it's palpable if a huge broad ligament hematoma is there. I'm talking of those neglected cases in which the cervix pura uda hua hai and going the lateral wall of the, uterine artery involvement is there. Otherwise, in a institute, if it is delivered and we are not getting the apex, we just tie it below, take a thread, try to take the sutures on the upper side, and then the remaining stitches, and then packing it works sometime in various type of tear.
So will you go for packing in this case or laparotomy?
I told you that if it's involving the uterine artery and descending cervical, I prefer to go for laparotomy because I have to save the patient.
Cervical apex laceration is not seen.
Apex
Sir,
is
if
not
there is
seen laparotomy.
If there is a shock is out of proportion, that maybe we are dealing with some broad ligament hematoma or something.
Yeah, so we have to open the patient that time.
Yes, ma'am. Don't
And
hesitate
sometimes
to
there be some retained
open
products
the
could be
abdomen.
there. That also we have to rule out.
Yes, if you are not
Small
getting
bits
the cervical lacerated apex, it is better to open the go for the open surgery, laparotomy, and repair the defect.
There,
This is the case I was operating. It's around 30 weeks pregnancy. You can see the hematoma. Case of the placental beads also. So what are the causes of rupture uterus in your practice? Dr. Nandini?
Most commonly VBAC, not in our
Scar rupture, scar rupture.
patients. And scar rupture is the most commonly we get from peripheries when the patient has been given trial for the entire night, and the early morning they come on a stretcher, and the patient is hypotensive and shocked, and the baby head is stuck in the vagina, and the history of previous cesarean, and then you open and it is a hemoperitoneum. That is the most common presentation of rupture we get. Or obstructed labor, multiparous patient, multigravida patient, or being given a trial of labor for around 12 hours, not delivering, and then coming early morning on a stretcher, again hypotensive and in shock. These are the most commonly we get at the street.
Injudicious use of oxytocin is most common cause of unscarred uterus in our setup, sir.
And also misoprostol, Neetu.
Misoprostol by ASHA
Available,
workers.
they are using misoprostol.
Nowadays, it's
Injudicious
misoprostol
use of
mostly.
misoprostol by birth care attenders and ASHA workers who bring the patients, especially
Exactly,
in periphery. That is the most common, I
Most
feel.
common, yes.
When we have seen gravidas, no, they are coming with rupture uterus
Exactly.
because of just misoprostol. No,
So have you come across a patient of a rupture uterus which had undergone either a myomectomy or septoplasty in past?
Myomectomy, yes, sir. Myomectomy,
myomectomy, yes, but
septoplasty wale bhi. Septum resection, I have not come across yet.
Okay.
no, they are too cautious. No, after undergoing myomectomy and septoplasty, they are too cautious.
Yeah.
They
Point I
have
have to highlight here is
regular
that
examination. They have such regular ANC visits. I don't think this is possible with him.
Yeah. मतलब elective surgery वाले patient, they are coming with the regular visits. They are very well aware कि
Right,
उनकी कोई surgery हुई है. But neglected second stage of labor, misuse of these misoprostol, misuse of oxytocin, and a very bad quality of rupture, we are getting those patients more in our medical college.
And the crucial decision that is that which uterus we have. We
the uterus also, because it is only para 1.
Right, that decision depends on many factors, like the parity of the patient, how bad the damage is, how bad the uterus has damage, and how whether it has involved other organs as well. We have seen bladder rupture also in such cases.
Importantly, the condition of the patient.
Secondary to the forceps application, the the inexperienced person applying forceps in panic, and when they don't realize that the sutures are not rotated and there is not enough descent, and they try and they just pull, and then it leads to ugly rupture of the bladder as well.
Yes.
And most importantly, the condition of the patient. When she comes in shock, nothing is there, despite everything.
But I think obstetric history is one thing that actually plays a very important role in taking the decision whether to go ahead with obstetric hysterectomy or try your best to preserve the uterus.
Right. The preservation of uterus is more important. Monica madam, how much time we can go ahead with this panel discussion?
We are close to 4 hours now. I think we can stop at 8 o'clock. We have got another 5 minutes.
Just few questions, and we will have a rapid fire from Dr. Rujita. Rapid fire question to all the panelists. Next question is how to prevent the PPH. Mitra madam.
Be prepared for PPH is the only
Anticipate. And first of all, in antenatal time, patient should be, not anemic. If she's RH negative, you should be very cautious about arranging blood. Even if she's, 12 gram hai, to bhi आपको RH negative patient में, you will find out that PPH atony happens more often in the low risk cases than in high risk cases. So that is a paradox, but we are confronting PPH in low risk patients more. So anticipation, that means correction of anemia, availability of blood, and proper monitoring of labor. Like what you all have said, the horrifying images of ruptures and all happen when there is indiscriminate use of oxytocics. So judicious use of oxytocics, not allowing the woman to labor for too long, too exhausted. All these are things which are going to cause her to go into atony. So it has to be, I wouldn't say ki programmed labor, but somewhere we should have a timeline ताकि ये patient इतने बजे तक deliver हो जाएगी, then we know she'll be uncomplicated. Otherwise, we should take decisions safely, timely, early. And then, of course, be prepared. Your PPH drill is very, very important. And all of you who are my friends and know me and my craziness, I've been trying to promote the creation of drills. And I'm happy to say that in our competition, lovely drill videos have come out in AICOG 2025. They'll all be showcased. So the concept of preparing emergency drills in all medical colleges, and you all are actually the leaders. So सबको train करो, हमारे जैसे people who are in single units, for us and our staff to be ready. आपके यहाँ तो रोजाना PPH होता है तो सब जने रोजाना ट्रेन हो जाते हैं, बट हमारे यहाँ पर तो वंस इन अ ब्लू मून होता है तो सबके फंडे गोल हुए पड़े होते हैं. तो you have to keep up the knowledge level of the team as well.
Yes, madam.
So
Madam,
I'm
that's
really
why
glad,
that
Monica,
madam,
that I
madam.
had given up because I thought मेरी आवाज गई हुई है, पर लगता है दिमाग तो नहीं गया था ना. तो काम. I enjoyed, Sandeep, your panel was very good, and inputs by Dr. Neetu, Archana, Dr. Shabana, Dr. Megha, Rajata, Nandani. I can see all of you. If I'm missing somebody, Manisha and all,
Yes,
everybody
madam.
is given fantastic
Madam, for a
inputs.
single
Others,
unit.
please give your learning.
Yes,
And
madam.
madam, these are not the original panelists. These are not the original. They are all temporary
मोनिका,
arrangement.
I'll tell you what, जो लोग PPH को मैनेज करते हैं ना, वही सबसे अच्छा बताते हैं. तो ये सारे धुरंधर शेर बैठे हैं तुम्हारे आसपास.
Madam, मेरे को ma'am, I tell you, Bhopal, such a lot of medical college, all of them are my friends, and they are fantastic, all of them.
Yeah, brilliant.
And madam, another thing you said, talked about the SOGC guidelines in infertility and ART also, ma'am. The SOGC guidelines and Australian are the best.
They're more logical. वो ना घुमाते नहीं है. They're not like red tape. मुझे तो सारी guidelines पढ़ने के बाद ये लगता है कि जितना घुमा दें उतनी बढ़िया recommendation समझते हैं, और हमारे को लगता है जितना to the point. And you will see that Dr. Jaideep Tank, he takes a lot of his content from the Australian guidelines and SOGC. They're more direct and very intelligent guidelines.
True, madam.
हाँ, चलो, great.
Yes, madam.
छा गई तुम तो आज, मोनिका, अर्चना, सब जने. हाँ, करो डॉक्टर संदीप, रैपिड फायर करो भैया.
Yes, rapid fire करते हैं. Now Rujita is there, madam, to conduct the
Yeah.
rapid fire.
Sir, can we have those slides? See, very simple questions actually, and we have discussed everything, but just a rapid thing. Most common cause of maternal death worldwide.
It's
Right.
PPH.
Yeah.
PPH.
Two important underlying high risk factors for PPH. According to you, what are the two most important high risk factors for PPH? I mean, what you are actually afraid of most?
Anemia.
Yeah, anemia.
Severe
Yeah,
anemia,
Hypertension.
multiparity.
but I would say it's the preeclampsia. In our setting, it's the preeclampsia. The burden of workload is because of the preeclampsia. So everything, every postpartum hemorrhage, they have some or the other things related to preeclampsia, which leads to postpartum hemorrhage. And of course, anemia is the predisposing factor. So what percentage of maternal deaths are attributed to PPH?
35. अब now
38%.
recent data 38 बता रहा है.
Right,
38%.
So it's somewhere around 25 to 30%. What is the recommended blood loss threshold for diagnosing PPH in vaginal delivery? It's very simple.
It's 500,
500.
What we have discussed most common cause of secondary PPH. So according to you, what is the most common cause of secondary
Retained blood infection.
We have not discussed actually secondary PPH, but it again has a very, the patient of secondary PPH does not bleed torrentially, right? But she bleeds for a prolonged period of time, and which ultimately leads to her exsanguination. So, what are the causes of secondary PPH?
Infection and
Retained POCs and AV malformation and aneurysms are the second most important causes of secondary PPH. Long-term effect of intractable PPH. Have anybody come across this?
AKI.
AKI is the most common. And has anybody come across Sheehan syndrome?
Yeah, she has. Another thing is, you know what, Rujuta, not just this, what you have mentioned, Sheehan's, but you know, what are the long-term effects of these, compression sutures and ovarian uterine artery ligation? I've found patients having this Asherman's after compression sutures. So there are long-term effects of our resuscitative surgery also, you know.
A very bad patient of sepsis, where when we again reopened that patient because of that B lynch, the uterus was actually necrosed. It was blackened because of compression sutures or the kind of this thing we giving, the pressure we are giving. This is very important. So we are compromising the blood loss. So at the same time, we should keep in mind that we are compromising the blood loss for uterus. So uterus may get necrosed in future. Right. So we have seen this. She went into septicemia and ultimately she died because of this. See, this is, we have this discussed. The one thing, what is your choice when we give blood transfusion, whether it is a whole blood or packed red blood cells?
PCV, blood components are better.
Yeah. So it's always the blood components, because for whole blood is not given for hypovolemic shock. The hypovolemic shock is to be managed with the intravolume expanders. Right?
In fact, whole blood is not advisable in anything. Now we have packed blood cells and all the components.
A lot of antibodies, lot of reactions, lot of infections we are transfusing because of this whole blood. Sir, can we have this slide? Next slide.
Yes.
Yeah. And in cases where the uterine atony is refractory to medical management, which intervention should be considered that we have discussed? I think it is the tamponade and then the surgical management. What is the best prophylactic measure before doing LSCS in a very high risk patient? So this is the topic I again want to discuss, because this is my personal experience. When we give misoprostol, even before this thing, as soon as the anesthesia is given, or as soon as if the patient is under general anesthesia most of the time, so as soon as the patient is intubated, if you put misoprostol then and then only, so we get some time to act, the misoprostol to act, and it actually gives you very good results. So we can think of putting a rectal misoprostol.
Baby literally walks out of the abdomen also. That is my personal experience. But in few cases, you have to be very guarded around that. Especially in case of previous 2 cesarean sections. Sometimes in one, if you have lots of additions,
Right.
That
is the only thing.
and multifetal gestation.
Yeah.
But when I had one case in which I was trying to deliver the first baby, but the second baby pushed my hand and he came first, the male dominant baby. So there I felt I shouldn't have given misoprost. The time was taken quite because it was difficult to previous cesarean section. So these are guarded cases where we have to take, but misoprost is very good. And even oxytocin, after giving spinal with good fluid given, you can give 2 units, 10 units of this thing in the pint and start a procedure.
I think the rest of the questions, I think we have discussed. We know the answers. You are all actually, we have been managing these patients day in, day out. I just want to have one take-home message from each one of you, which you feel is very, very important when we manage postpartum hemorrhage, or when actually we manage any patient of obstetrics. So one take-home message. What is the most important thing that should be taken into account?
Take every woman
Good
as a high risk
teamwork
woman.
and communication. Good teamwork and communication.
Yeah, teamwork, the help. That means we should have our circle ready where what we call people can rush to us in case of emergency.
See, so Ruchita, I'll divide cases into two cases. One is booked and one is unbooked, right? So when the case is booked with you, give a thorough time to, at the first visit, I invite the family also once because I want to know what circumstances she's into it. We are advising everything, whether she's taking or not.
Right.
That is very important. You have given iron calcium, but it is not reaching her because of her any other issue. So that is the time when the family counseling should be taken place. Give time for the lab investigations. I usually repeat, do first on the admission, then repeat at the second, I mean, 7th month when it starts. Proper ultrasound screening, where you can do the placental mapping as early as 10 to 11 weeks. This is your book profile. Your team is managed, you have trained everybody. Unbooked case, call for help, have your anesthetist and friend in need is a friend in need. That is very important. Whenever you tell them this is an unbooked case, I am entering into that, maybe I'll need your help. And other things come hand in hand.
And I feel when every
Thank you,
woman
ma'am.
should
Any
be
question,
considered
ma'am?
a high risk woman.
Manisha, ma'am?
I think every woman should be considered a high risk woman because many times the low risk women they'll end up in PPH and we are less of observant or we are like overconfident. So consider everyone and a small PPH. Sometimes there's a small blood loss which goes into major blood losses. So that has to be taken.
Dr. Megha? Thank you, ma'am.
So, ma'am, most important is that we need to have preparedness. So, anytime we are having a patient in labor, you have to ensure that we have all the drugs ready, and most importantly, we have the blood available and cross-matched in our blood bank. Because at the last moment, running around for blood products, searching for drugs, it becomes very chaotic. So, when we also have a team together, we need to have the things together so that we can manage, anticipate, and manage PPH as and when it occurs, so that we don't waste much
Yeah.
time gathering ourselves.
In government hospitals, we have this facility. We have this multidisciplinary approach. We have different specialists ready. But in private nursing homes, it is not the case. So selection of cases and where to deliver that patient, I think the place where we want to deliver the patient is also important, I think.
Can I add my learning also? So
Yes,
one thing
ma'am.
is that a very updated, complete PPH kit should be there in every labor room. So all those who have done their Manyata training, or even if they haven't done it, but all of us who have listened to Dr. Sheila Mane since so many years, we are having the PPH kit in our labor room. So everything has to be not expiry. ये नहीं कि इंजेक्शन पड़े वो expiry date के oxytocin है वो cold chain नहीं maintained है. You don't have gloves. In fact, in my PPH tray, I also have marker pen and blood, sample vials and forms, everything in one place. Scissors, tapes, every damn thing which one can find, need at the time of emergency in PPH is present in that thing. Long gloves, हर चीज Foley's, सब कुछ है. So one thing is that, and second thing is that see you started out nicely with the patient, but if she starts bleeding, I would say that you should inform the relatives and should take a consent side by side. So I never do this कि मैं consent नहीं लेती. I will call the husband or some intelligent person, let them know that we are dealing with attorney, and I dictate the things which I want to my staff, and then they take a detailed consent in Hindi, so that the patient and the husband cannot refuse. बाद में GA में चले जाएगी तो they will say हमें तो बताया नहीं क्या हो गया क्या नहीं होगा. So we have to be prepared in managing the PPH. We have to be ready with the consents also. Do not forget the importance of taking. अभी जो मेरी प्राइमी थी, जब मुझे उसका GM I mean like एनेस्थेटिस्ट को बुलाना था, मैंने पैक कर दिया था. मैंने हस्बैंड को बुलाया और समझाया कि देखो ऐसे ऐसे किया है, ये अभी कोऑपरेट नहीं कर रही है, हमको इसका टाका लगाना है और इसको मतलब आप.
Ma'am, you are muted.
Host, please unmute, madam.
So I think it's very, very important that we should not forget about the consent. Rest everything you all have covered so beautifully. anemia and
Thank you
preparedness.
so much for that invaluable inputs, ma'am. Thank you so much.
Rujita, Sandeep
Madam,
sir,
you have
I would
already.
like to extend my invite. Mitra madam is coming to our place,
वो
Vadodara. in
पेशेंट कल
September.
पहुंच जाएगी.
Yes, ma'am. Invitation आ जाएगी और हम लोग सितंबर में होस्ट कर रहे हैं Foxy conference in Baroda, where madam has got a special session on internal ligation and all these things. So please join us.
Madam,
Invites
you
will be
first join
sent.
us, madam. We are conducting BuzzCon in the month of August, and that's a Foxy
Yeah, I
Presidential
just saw
Conference
that.
BuzzCon.
Love
And
to come to Nagpur,
as
sir. It's a very, I mean, Pragati is there,
yes,
Vaishali is there. There are so many people. I look forward to coming to Nagpur.
yes, madam. And now we are inviting Dr. Sheila Mane as a speaker and to conduct a workshop. So
Madam
it
is
it will be a delightful for all of us.
PPH lady, we call her, sir.
Yes, yes. And finally, I would like to add that three things you should have in your labor room. That is PPH team chart should be ready.
मैं तो
PPH
इससे
kit
चला
should be
दी हूँ.
ready, and it should be kept in the refrigerator. And PPH drill every 6 monthly.
वो भी हो रहा है, पता नहीं इसका जो साउंड है ना किर किर हो रहा है.
Perfect, sir.
You too, madam.
Sandeep sir, one thing I would like to add, it was a very, very practical and a very simple panel. You made the slides so well. I mean, and we are all very into it. Actually, we did. You can see Mitra, madam, everybody with passion, everybody with. And thank you, Monica, for roping me at the last moment. I would have missed it agar wo hum itna sincerely sunte na when you are a part of it, more sincerely. So lots of learning
And
activities. Thank you so
in fact,
much.
I was quite depressed when none of the panelists joined except Megha. But then I said, "Sab log join kar lo. Call Shabana, call Manisha, call everyone." And you
Right.
did such a good job.
No, it's a day-to-day practice, day-to-day
enjoyed.
topic, and we are managing it every step of the.
Very practical scenarios.
Yeah, and
Thank you for that. And Ruchita, your rapid
Sandeep
fire was
wanted to
very good.
include about more panelists. Yeah. Sandeep wanted to include more panelists, but unfortunately the flyer was ready. There was some miscommunication. But Sandeep will definitely do it again. We'll do it.
Yes, madam.
We
Now
thoroughly
you have to come to
enjoyed.
Nagpur,
I
madam, for
agree.
that BuzzCon.
Yes, yes. And Dr. Sandeep, you are a very mature and very cool and very chilled out moderator. Totally.
Yes.
You make everybody feel very comfortable.
That is the right word.
So,
Thank
and
you.
Mitra,
Thank you, Monica
Mitra
ma'am, for this
Mitra,
opportunity.
and
Madam, thank you.
Rujita,
Word of wisdom.
your last minute inputs and the rapid fire
fire.
round and the take home messages were fantastic. Yes, rapid fire.
That should be take home.
So,
Type से सबको रखना चाहिए rapid fire end में. So
Yes, yes.
I have taken it into my mind.
Can can we stop the slide share, Sandeep, so that we can just, say bye to each other?
Yes, yes, madam. Thank you, madam.
Thank you so much.
Bye, Sandeep. Monica and myself
Thank you, Dr. Sandeep.
for post of practical obstetrics and myself for midlife management committee. Do support us and looking
Yes.
forward to work together in near future.
I'm not for practical obstetrics, I'm for perinatology.
Perinatology, sorry. Mitra ma'am.
Archana, you changed
No,
my committee.
I'm sorry. I'm eating it back. Monica को तो पूरा support है.
Doesn't matter, कोई बात नहीं.
We both are together only. We would like to work
We are all working hard.
It's
So
like
thank you
brain
so
fogging, I think, Monica, with so many things going on.
It's okay. It's okay. I mean, we all are, thinking about each other, and the team is really working very hard. And, with elections, we are doing such fantastic academics. That's the whole thing. Somebody was telling me it is very difficult to keep a series going.
Actually, and
we
it's
reached 13.
the quality of maintained is
Yeah.
fantastic.
So we reached 13 episodes of perfection. This is the 12th
This is the
episode of
12th one.
Symbiosis. So we have completed 25 webinars in just over a year. And we have so many other in the pipeline. So thank you, Bhopal
It's all your
Obstetric
effort,
Society.
madam.
Thank you to our team. Our team is all here, and you all, and this is the gentleman behind Symbiosis and Perfection, Dr. Vishal Dave, who is not speaking anything, but he is the man behind the whole show. There is nothing he cannot do. He makes the most beautiful flyers. He's very sincere, very conscientious, very humble. And we love you, Dr. Vishal, all of us.
Thank you, ma'am.
Thank you so much,
Thank you,
Sandeep,
Vishal.
for a wonderful panel. Thank you, Mitra ma'am, and thank you, everyone. Thank you, Archana. All the best. Thank you, Rujita. Thank you, Dr. Megha, Nandini, Neetu, Manisha. Vinita ma'am is still there, I think.
We
And,
can
Thank
stop
you,
share
ma'am.
and take
Thank
our
you,
good
ma'am.
pictures together. If we can
yeah.
stop share.
Sandeep, can you stop the slide share?
Yes, yes.
Yeah, we will be all full screen then. We'll take a screenshot. Yeah. Okay. Say cheese. Okay.
It's got very nice dimples, you know. So see you all, everybody. Enjoy it, Monica.
The next Symbiosis is 28th of May with Young Talent Promotion Committee and Quiz Committee. So it's going to be something very out of the box ideas we are coming with. It will be total non-academic fun dhamal type of YTP webinar in which 3 generations of gynecologists will discuss the pros and cons of their lives. Their work-life balance, their family balance. We'll have 3 generations. One is the Mitra ma'am generation. Second is, thoda sa Archana or Mera wala generation. And third is these youngsters generation. Nandini and Neetu. So we'll have
Madam,
discussion
all
on
are
how.
all are from young generation, madam.
Yeah, forever. We are stepping
We
into
are
Akshay Kumar's shoes.
So that's it. And I take this opportunity to invite you all to Bhopal. Also, we are having a conference, 12, 13, 14 July. West Zone BP conference is there in Bhopal. If you want to see the beauty of Bhopal in monsoon, you can come. There are a lot of trains from Nagpur. Sandeep?
Yes, madam.
Yes. So
Where
because my son is studying in Nagpur, I know he comes very often. So I have got a special connect with Nagpur that ways. Thank you so much. Have a very good night. And
Good
thank
night,
you
Thank you
madam.
so
so much,
much.
ma'am.
Bye.
Thank you
Bye.
so
Bye.
much, sir.
Bye. Good night.